Is it visible now?
Yeah, yes, you can start.
Yes.
So my presentation is on vision assessment in infants, including the electrophysiological test. This is a very vast topic, so I've tried to do justice to the topic by dividing it into two parts. So the first part is it's not moving. Yeah. Any pediatric examination is a big challenge. Assessing visual acuity is very important because this is one aspect of visual function for which we have well established, validated tools available, and also age matched normative data is available for these assessment tools. Early detection of visual impairment is essential because it has an impact on the psychomotor, cognitive, and social development of the child. And also, poor vision can be an early indication of a serious life-threatening disorders like retinoblastoma. Visual acuity is defined as a motor or sensory response to a threshold stimulus of known size at known testing distance. There are two important points to consider. First, the results have to be matched with the age-matched normative data tested with the same assessment tool. And secondly, these results are not necessarily predictive of visual status later in life. The visual acuity includes detection acuity, resolution acuity, and the recognition acuity. In normally healthy infant, usually the fixation is developed by 2 to 3 months of age, and the accommodation develops by 4 to 6 months. Deuteropsis develops by 4 months. So we have a plethora of tests which are available for assessment. Depending, they have been divided according to the age group. So we'll be dealing mainly with infants and the preschool children. Blink reflex is usually learned by an infant around 30 weeks of gestational age, and whenever a bright light is shown in an infant's eye, usually blinks. But if that visual behavior is not observed, in those cases, the eye-popping reflex indicates the infant's ability to detect changes in the room illumination. Blink reflex to a threatening gesture is observed by 5 months of age, and it is tested under the monoocular conditions. Fixation of a child is achieved by 3 to 4 months of age, and central, steady, and maintained fixation is a very useful test. In this, when a child fixates on a light source, and we have to note the location of the corneal light reflex, and if it's steady, whether it's maintained by looking for maintenance of fixation in either eye, and it also helps detect amblyopia. There's another test, like in this child with squint, we wanted to assess the vision, so we checked for the fixation. Once he was fixing towards the colorful target, and then we looked for whether he's following the toy in all the different directions of gaze. The horizontal tracking is followed by the vertical tracking, and this is established in a child by around 4 months of age. Preferential looking tests are based on the principle that infant prefers a pattern stimulus in comparison to a homogeneous field. We have the tail equity cards, which are very reliable and efficient test. In this, we have on one half of the card there's a vertical black and white bars, and other half it's a uniform background, and there's a hole in the center through which the examiner is observing the infant's fixation, and it is quite successful in most of the clinical settings. The Cardiff Equity Test is also based on the same principle and is useful to test the vision in the toddlers as well as the infants. We can see. Now you can see here that the pictures which are visible, these picture optotypes are called as vanishing optotypes because they're visible at only a particular distance. The toddler is able to detect and also recognize these picture optotypes. Then comes the optokinetic nystagmus test. This is an objective test in which once the optokinetic drum is rotated, we get a nystagmus response. And that has a slow component in the direction of the drum rotation, a fast component in the reverse direction. You can see here a horizontal nystagmus coming up. And if we rotate the drum in a horizontal direction, then there's a vertical nystagmus which is induced. See this vertical nystagmus coming up? In preschool age children, we have a plethora of tests which are available, and I personally prefer the Lee symbols test because these symbols, they have a right to left to right symmetry, which overcomes the child's sometimes problems with the horizontal laterality. And other thing is, this is very useful in non-verbal children also because there's a play card which is available and the child can easily match these symbols and answer the questions. As pediatric ophthalmologists, we often come across these children who have poor visual acuity, they're not able to fixate, and the parents have a question that, is my child able to see? What will happen? What is the prognosis? And so many questions are only possible to answer if we know what is the exact diagnosis. So here comes the second part, the role of ectophysiology. This is a diagram of the retinal architecture where you can see that the visual information, it flows vertically, and the different stages of the visual processing, they can be probed with the different electrophysiological tests. The first is the electrooculogram. This actually evaluates the function of the RPE. It's very essential in diseases like retinitis pigmentosa and Best disease. The graph here you see has a dark phase and the light phase. This is a normal subject, and the below is a case of retinitis pigmentosa. We see in the dark phase, the graph is almost the same, but you can see the reduced response in the light phase. So these are very essential in diagnosing children who have a family history of retinitis pigmentosa early. Then comes ERG. The role of corneal electrodes has already been established in ERG, but it's not very useful in pediatric population because we have to anesthetize the child. So here comes the role of skin electrodes. These electrodes are widely used now, and there are lots of studies who support that they have reliable results. The other important point is that the ERG amplitudes are well established by 12 months of age, and which is within 10% of the adult values. There are different types of ERG. The one is the full field ERG, which is the flash ERG, and it has 5 different components. The first component here you see that is photopic response to a dim flash of light, which is mainly the rod response. And then we have a response to a bright flash, which is a combined rod and cone response, where you get the A wave, which is the negative wave, followed by the B wave, the positive wave, which is because of the bipolar cells. Then there's a response of the oscillatory potentials, which is because of the amacrine cells. And then the photopic responses, which are the cone-mediated responses. This gives us about the information about the whole of the retina. Then comes a multifocal ERG, which is basically it helps to localize the spatial damage of the retina. And here the light adapted eye is stimulated by an array of hexagons. And the central hexagons, they give the maximum response. Then we have a transient pattern ERG, which helps differentiate between a macular function and a ganglion cell function. Here, the stimulus is basically reverse the checkerboard pattern. This was a paper in which the ERG characteristics in children with infantile nystagmus syndrome and early onset retinal dystrophies were established. And we can see there are 6 phases, and in 6 phases in this graph we have different groups. The A is the control group, and the B, if you see there's no ERG recorded, this is the case of Leber's congenital amaurosis. And C, we have electronegative ERG, a case of CSNB. This D was a group of achromatopsia where you can see the cone responses were markedly reduced. And E and F were groups of retinal dystrophies, the rod cone dystrophies, where both rod and cone responses were reduced. So to discuss these cases, when an infant comes to you with a history of decreased visual acuity, nystagmus, and a normal fundus, then how do you go for it? ERG is the diagnostic tool. Here you can see that there was a reduced response in the B wave, and more than that, there's an electronegative ERG, which is characteristic of CSNB. Another group of patients with the same complaint with added photophobia feature, you can see that the cone response is not established. This is a case of achromatopsia. And in this age group, sometimes you don't get a history of a defective color vision as well. Another patient with decreased poor visual acuity, if the fundus is normal, then ERG is the tool. Not recordable ERG, VP is markedly reduced. And it is very essential that, ERG and VP, they can be done at the same time, because this is it takes around 40 minutes, and we are able to get a retinal response as well as the macular function at the same time. Then a case of nystagmus in a baby in which the ERG showed that rod and cone responses were reduced, delayed VP, typical of retinal rod cone dystrophy. Coming to VP, this is an objective tool which helps us to record and also to monitor visual acuity. It's always done according to IST guidelines. It is seen that by 4 months of after full-term birth, latency is within 5 milliseconds of the adult values. There are lots of papers to establish it uses in infants, which show that it detects lesions in the visual pathways, it confirms the functional loss, and also quantifies the visual impairment. We have the flash VP, the pattern VP, pattern reversal PP, using the reversal checkerboard pattern, and we have the pattern on-off VP. But if we compare 3 of them, the pattern reversal is the most reliable, and it has P100 wave, which is the principal measure. Sweep VP is another test, which is modification, which is basically done to estimate the visual acuity and detect amblyopia. Multifocal VEP is very essential in diagnosing the local defects which may be missed by the conventional VEPs, especially in optic neuritis cases. Everyone knows the role of VEP in making a diagnosis in case of albinism. We know in albinism we have a defective anomalous decusation at the optic chiasma. So this crossing asymmetry is picked very well on flash VEP. And in achiasma conditions, we will have insufficient crossing of the retinal fibers, and with which we can differentiate these two disorders.
You'll have to, 30 seconds only.
Is a comprehensive task. For detection and evaluation of visual impairments, all elements have to be compared with visual function of daily life and with the same assessment tool. Vision assessment of every age group to be compared with the normative data of the same age. Results of visual impairment to be explained to parents and the guardians to help them to understand the situation and strengthen their interaction with the children to reduce the visual disability. And not to forget the role of electrophysiology being a wonderful diagnostic tool in diagnosing the causes of poor visual acuity in this age group. Thank you.
Thank you, Reena. We'll have the questions at the end of the session and also the panel at the end of the session. Let's first finish all the topics. Then the next, thank you, Reena, very good. The next speaker, we have Dr. Subhash Dadia from Maulana Azad Medical College. He doesn't need any introduction, and he has a specific topic of diagnostic training in amblyopia. Dr. Subhash Dadia.
Thank you, sir. At the outset, I would like to thank the SPOSI and Punjab Ophthalmic Society for inviting me. I will be speaking concept of diagnostic training in management of amblyopia. So basically, amblyopia is derived from Greek word which means dull vision, and clinically it is defined as unilateral or bilateral reduction in the best corrected visual acuity, which is caused by foam vision deprivation and or abnormal binocular interaction without any visible organic cause. The visual acuity should be less than 6/12 for bilateral amblyopia, and there should be difference of 2 or more lines for unilateral amblyopia, and it is correctable if appropriate measures are applied at appropriate time. So for diagnosis of amblyopia, there must be evidence of reduced visual acuity, there must be presence of amblyogenic factors, and there should not be any alternate cause for loss of vision. Various treatment modalities for amblyopia are refractive correction, patching, penalization, near visual acuities, pharmacological therapy, LASIK, omega fatty acid, smart glasses, and now the focus is on behavioral therapy, and dioptic therapy is part of this behavioral therapy. So the question arises why there is need for dioptic therapy. Patching is quite effective in children, however, effectiveness decreases in adult patients. And this decrease in effectiveness has been attributed to decrease in plasticity of the brain. Recently, adult brain has been shown to have much more plasticity, and in support of this, new behavioral treatment have been developed, which leads to improvement in visual acuity, stereo acuity, and contrast sensitivity. So basically, it originates from the idea that amblyopia is inherently binocular disorder rooted in intraocular suppression. Therefore, effective treatment should be to engage both eyes as per Hess et al. And they have tried static-based games were developed in which game pieces were presented dioptrically such that some were seen by one eye, some by other, and some by both. So basically, it is dissociation, contrast, rebalancing. The participants with amblyopia are trained on those tests in which stimuli are presented dioptrically with contrast image to fellow eye attenuated in order to encourage binocular combination of two inputs. Basically, it is to view separate and independent images simultaneously by each eye. And this training reduces the fellow eye contrast to rebalance the contrast between two eyes. It promotes binocular vision, reduces the inhibitory interaction within brain, and reduction in suppression leads to improvement in binocular vision. And repeated exposures leads to further reduction in the suppression and further improvement in binocular vision. So what are the drawbacks of this therapy? Basically, most of the treatment modalities which have been tried, they are not home-based. It needs supervision and long-term results are not known. Hess et al. Concluded that binocular vision is not lost in amblyopic patients, but it is rendered to functionally monoocular by active suppression. So the fact is that monoocular improvement occurs in absence of any fellow eye occlusion, suggests that amblyopia is a binocular problem and is in part due to chronic suppression. So basically, can amblyopia be corrected in adult patients? The answer is yes, because regardless of person's age, the visual system, which consists of the eyes, brain, and visual pathway, can be retrained due to brain's plasticity, and the visual skill that needs to be retrained is binocular vision. So basically we want to view the separate and independent images simultaneously. So near visual activities are often prescribed during patching from myopia based on the assumption that those activities they stimulate the visual system. ATS 6 was conducted to determine whether performing near activities while patching from myopia enhances improvement in visual acuity. The conclusion was performing common near activities does not improve visual outcome in treatment of myopia. However, there are other studies which are contrary to recommendations of ATS 6. So, in myopia, visual impairment is lifelong. The child may dislike patch, eyeglasses, and drops, and even using myopic eye. So, television has been a very popular mode of entertainment, and there has been a general myth among common men that television viewing, and especially from too near, has been cause of many eye problems, mainly of refractive variety. So, why we choose television? Because it is easily accessible, colossal influence it enjoys in our life, and fondness with which children watch it. It is an effortless method of providing stimulus to myopic eye in children. So basically, we conducted a study regarding role of television games in treatment of myopia, and we have noted that there was improvement in distance visual acuity, near visual acuity in both the groups, but was found to be better in television game group as compared to full-time patching in treatment of myopia. Although ours was a small pilot study, based on our results, we recommend use of near visual activities in the form of television games, along with full-time occlusion in treatment of myopia. We have published it in Journal of Strabismus. Then video games have been tried by Ghosh et al. And they concluded that improvement in visual acuity and binocular functions for patients in older age group can also be achieved. Then, is there any role of mobile exercises as an adjuvant to myopia therapy in children? We conducted another study, and objective of this study was to study the role of mobile game exercises as a form of near visual activity along with 2 hours occlusion in treatment of myopia. Why we choose mobile games? Because they are easily available in every household. They are popular mode of entertainment among children, and loss of binocularity is one of the defining feature of myopia. So now focus is shifted from monocular interventions to interventions that directly target binocular functions. This has led to increased interest in the development of myopia treatment that direct and address binocular dysfunction by promoting binocular vision and reducing inhibitory interactions within the visual cortex, such as mobile games, as a form of near visual exercise. Hess et al. Has found restoration of simultaneous binocular perception and increase in the stereopsis, and this is direct evidence that myopia may be consequence of primary disruption of binocular vision, in which suppression plays a major role. Mobile games, they strengthen the fusion and they reduce the suppression.
So and you will have to conclude, please.
Sub 2 minutes or more. Okay. So basically, the gameplay method is stereo. Block is played with sliding finger. So red blocks are only shown to myopic eye, while green blocks are shown to sound eye with the help of red-green glasses. In this session, the brain is forced to use both eyes together in coordinated way during the game, which should lead to better coordination. While by putting blocks over other, score increases by 100, and on making the horizontal line, the score increases by 100, and in this way total score of each exposure will be calculated over 2 hours. So basically this is the game method, and the color of each eye can be selected along with saturation level, and we have found that the average game score increases with the prolonged exposure of the mobile games. And we would like to conclude mobile game exercises as a form of near visual activities along with 2 hours of occlusion allowed improvement of visual acuity, which was maintained even after cessation of therapy. Thus, mobile games can be used as a useful adjuvant to occlusion therapy in myopia. ATS and in this binocular iPad treatment was not as good as 2 hours of prescribing patching. Then video games has already been tried. Myopia treatment with adults with dioptric training using visual reality Oculus Rift head-mounted display. Primary results are encouraging. Birch and colleagues have conducted a study and found it to be useful. Subsequent study looking at younger children confirmed the previous work. Binocular treatment of the myopia using video games is being conducted, and the results are awaited. Thank you very much.
Thank you, Subhash. You have a long history of amblyopia management and research in amblyopia. We will come to questions later on. You remain there on the please. Then the next speaker we have is Dr. Urmil from Rohtak Medical College again Institute of Ophthalmology, and she would speak on the pharmacological agents. Start, please.
Dr. Urmil, please unmute your thing.
Sorry. Okay, so good morning, everybody. At the outset, I would like to thank SPOSI and Punjab Ophthalmological Society for this opportunity, and also Dr. Shukla sir for providing me this particular topic so that I could explore, which I have not done before. So, role of pharmacological agents for treatment of amblyopia. This next slide is not coming. Okay. Now, what is amblyopia? Besides the standard statements which we often hear about amblyopia, it's a sleepy eye or it's a lazy eye. Of course, whatever it may be, but it is not a dead eye with dead brain connections. The connections are just lying dormant. And so why do we need to treat it? Because most common cause of preventable blindness in children and young adults is amblyopia. Prevalence is 1 to 5%. Visual loss is treatable. And persons with an amblyopic eye is at 50% more risk of blindness due to trauma, infection, cataract, and glaucoma. So the need to treat fast. And what are the myths which pertain about amblyopia? That it can be successfully treated only till the age of 6 to 8 years, which is not true. Part-time patching is usually practiced. That is also not true. Full-time is still being practiced. Patching is not successful if previously attempted. This is again a myth. Now, what are the goals of our treatment? To restore and improve visual acuity by two strategies. Present clear retinal images to the amblyoptic eye so that by eliminating the causes of visual deprivation and correcting visually significant refractive errors. The second is to make the child use the amblyoptic eye. Now, recommended treatment should be based on patient's age, visual acuity, compliance with previous treatment, and physical and social and psychological status. So what should be the perfect amblyopia therapy? It should be effective, it should have good compliance, it should be acceptable to the patients and parents, it should be quick in action, safe to use, easy to administer, cost effective, and well maintained. Whether it is occlusion therapy, dioptic therapy, or pharmacological therapy, they should follow these traits. Now, what are the choices of treatment available to us? The choices are, they can be used alone or in combination to achieve the goal. It can be passive therapy in the form of proper refractive correction, occlusion, penalization, where the patient experiences a change in visual stimulation without any conscious effort. The various active therapies where the patient conscious involvement is there and he follows a sequence of events, visual tasks to provide the effect. And these are pleoptics, near activities, syntonic phototherapy, role of perceptual learning, binocular stimulation, software-based active treatment, and of course pharmacological, which I'll be taking up. So what are the limitations of the various treatment therapies? Residual amblyopia is very common. Poor compliance is often seen mainly to patching, though it's considered to be the gold standard yet. Recurrence of amblyopia, poor effect in older children, and does not address the deficits in binoc. So then obviously they need to explore more and more. So I come to the role of pharmacological agents. Penalization is one thing which is involving the pharmacological agents while treating amblyopia. It is a therapeutic technique performed by optically defocusing the eye with better vision. It can be pharmacological penalization or it can be optical. I'll be dealing with the pharmacological one. The indications are non-compliant to occlusion patient, mild degree of amblyopia, maintenance after occlusion it may be needed, and an isometropic amblyopia. The pharmacological penalization is an effective method of treatment for mild to moderate amblyopia. 1 drop of 1% atropine is instilled daily in the good eye. Weekly instillations have also been found to be effective. It provides sufficient blood to force the child to use the amblyoptic eye for near and good eye for distance. It has got a cosmetic advantages also. Cyclopentolate can be used as an in-office test to predict whether we should go ahead with penalization or not. This in-office test, it provides the amblyoptic eye with full optical correction, while it deads the sound eye with cyclopentolate and removes the optical correction also. If the patient switches to the amblyoptic eye when we perform this in-office test, we can assume that the patient will be responding to the atropine penalization also. Now, it usually requires 3 diopter or more of hypermetropia in the sound eye to obtain this effect. Blurring the sound eye to vision lower than the amblyoptic eye does not guarantee a switch in fixation to the amblyoptic eye. Reverse amblyopia is always a threat, so children have to be kept under follow-up whenever you're doing this treatment. The various methods can be near penalization, where the fixing eye is atropenized and fully corrected for distance. The emblyopic eye is overcorrected. Distance penalization, when fixing eye is atropenized and overcorrected, while the emblyopic eye is fully corrected, and total penalization, where the emblyopic eye is again fully corrected. Now, these are the various pediatric studies and the various ATS results which were there. I'll just focus on the ones which are concerning us. ATS 1 showed that atropine and patching are equally effective as primary treatment for moderate amblyopia. Then ATS 4, it again said that weekend and daily atropine produce similar improvement for moderate amblyopia. Then again our concern was with ATS 9, which was conducted in 7 to 12 years age group, which showed that daily 1 drop atropine is equivalent in giving results as with 6 hours of patching. So what are the advantages of penalization? It is cheap, it has got better compliance, and the disadvantage, the entire list of systemic and other effects which are seen, untoward effects which can be due to the drug, risk of occlusion amblyopia, and doesn't work well in myopic patients. So unless penalization decreases the visual acuity of dominant eye below the amblyopic eye, this form of treatment is not advised. Now, what are the various other pharmacological therapy and what is the basis of it? The basis is that the plasticity of visual system during the sensitive period is dependent on input from non-adrenergic neurons, and thus it can be subjected to pharmacological manipulation. Precursor for the catecholamine, dopamine, a neurotransmitter, was known to influence the visual system. And catecholamine-based medical treatment has been therefore demonstrated to improve the vision in amblyopic eyes. So history dates back that various pharmacological therapies that had been used were oxygen, strychnine, alcohol, propranolol, bicuculline, exogenous nerve growth factors. But however, none were successful in terms of clinical applicability and effectiveness. So levodopa and carbidopa combination, however, showed good prospects. Kesametsu et al. In an animal study showed that even older amblyopic animals could recover some function if their brain was flooded with the dopaminergic drug. Dopamine has therefore been known to have an important role in retinal function and central visual processing. Now, how does dopamine, dopamine, because it does not enter the blood-brain barrier directly, so levodopa is its substitute, and it is a precursor of dopamine, and it enters the blood-brain barrier, and carbidopa, which is a decarboxylase inhibitor, it prevents the peripheral conversion of levodopa into the dopamine in the peripheral nervous system, and in this way, it allows the collection of levodopa more in the central nervous system, and in this way, it helps in reducing the dose of levodopa by about 75%. This all I've explained to you. So there was an RCT conducted of levodopa as treatment for residual amblyopia in older children. However, this was not very supporting. It said that in children 7 to 12 years of age with residual amblyopia, after patching therapy, oral levodopa, while continuing to patch for 2 hours daily, does not produce a clinically or statistically significant improvement. However, there were other studies, like Rogers et al. He again said that improvement in visual started, but it decreased 5 hours after the drug injection. These are various studies which few are supportive, more are, I would say maximum are supportive, few are not supporting. This was by Orge et al. He said oral levodopa can be of benefit in the treatment of amblyopia in older growth too. Repka, however, could not support the fact, and he said oral levodopa with patching provides no additional benefit over the placebo therapy. Kothari was in favor. He said oral levodopa should be combined with occlusion therapy only for residual amblyopias, means amblyopias which do not improve with vision after 6 months of patching. Rashad et al. Again favored it. Levodopa may be added to occlusion therapy. Dadia et al. Also conducted the study, and they said that improvement in visual acuity with levodopa is maintained, especially in patients younger than 8 years of age. There was another, these two also supported, again saying that levodopa can be used along with occlusion therapy and it will have a supportive role. Now, once we know that maximum are giving a supportive role, we should ponder about the dosage and administration of the drug. Levodopa is usually administered along with carbidopa in a 4:1 dose ratio, oral tablet or as oral suspension. Liquid suspension are also known. It is bitter in taste, so it should be taken with a protein drink and well tolerated in children. Thrice a day is the dosage, levodopa 0.5 to 0.7 milligram per kg body weight along with carbidopa 0.1. However, Ledger et al. Found that if we take the dose of 1.02 per kg body weight, it lowered the oral body temperature by 1.2 Fahrenheit. So we should restrict the dose less than 1.02 milligram per kg body weight. Now, what are the other effects of levodopa? It has been found that it improves the visual potential response. Once levodopa administration, pattern VEP has been shown to be improving along with the visual acuity. Similarly, the visual field changes. It was found that there was a decrease in the fixation point scotoma, which persisted for around 2 months after the levodopa therapy.
You will have to conclude.
Side effects. So please, 2 minutes are left still. Headache, nausea, dry mouth.
No, because according to our watch.
Citicoline. Sir, your watch is running. Just 1 minute.
1 minute. 1 minute. Okay, 1 minute.
Okay. Citicoline is an intermediate byproduct. It is also involved in the biosynthesis of cell membrane phospholipids. It is again, 1000 milligram intramuscular administration is given for 15 days. However, lack of well-defined RCTs do not allow us. Then there's another trial going on donepezil, but this trial is about to come in December 2020, the results, courtesy COVID. And then there's an important role of omega fatty acid as an adjuvant therapy in treatment of amblyopia. Study conducted in GNEC 2019. Omega fatty acids improve the visual acuity in patients in amblyopia and maintain improved visual acuity, but there is no additional benefit when compared to patching alone. This is another omega fatty acid whose role is being studied in amblyopia, which was planned but has to be yet take a start. So conclude, the inadequacy of conventional occlusion treatment therapy and non-compliance of patients led to an insight into the role of pharmacological therapy for the management of amblyopia. Although occlusion of the dominant eye is the best treatment modality for amblyopia, its efficacy decreases after 6 years of age. Various studies have shown improvement in visual acuity and VT amplitudes with these pharmacological agents. Levodopa may be considered as an adjunct to conventional occlusion therapy in cases with residual amblyopia and an older age group. Regression of effect after stoppage of therapy and occlusion amblyopia in younger patients, however, remain the matters of concern. Therefore, further studies are therefore needed to evaluate the full efficacy and side effect of profile of these agents. Thank you very much. I'm sorry for a minute late.
Thank you, Urmil. You please stay because it could be questions for you.
Okay, I'm
now. Dr. Santan Gopal will take some time, so I'm calling Dr. Karanjit Singh to kindly he'll be speaking on the sensory adaptations in strabismus. This is an important topic, and please, Dr. Karanjit Singh.
Good morning, everybody. My topic is basically sensory adaptation in strabismus. These are basically physiological adaptations in strabismus to overcome the visual confusions or diplopia. As we all know, there are series of conditional and unconditional reflexes. The conditional reflexes, they develop during the first 3 years of life, and they produces binocular input to the cortical cells, leading to the binocular driven cells in the cortex. Basically, these are the during first 3 years of life. And unconditional reflexes, they develop about 5 to 6 years. And as we all know that binocular vision is not inborn, it develops after some time. So if strabismus develops before 3 years, then adaptation to the normal development occurs to prevent.
How do I access my PowerPoint presentation onto this?
Leads to abnormal unconditional reflexes developing by the age of 3 years. Usually there are no symptoms if these develop before 3 years of age. If strabismus acquired from 6 years to adults, then binocular vision is well established and symptoms are likely to occur. But if strabismus is acquired at 3 to 6 years, which is a crucial period, then symptoms will occur, but the system is unable and readily breaks down, and adaptations will develop, and that period is known as the plastic period, and symptoms are unlikely to occur during this period. So binocular vision is basically emphasized in two ways: the visual confusions and diplopia. So how does the visual system cope with these two conditions? In young patients, the sensory adaptations overcome diplopia and the confusions. These sensory adaptations are basically in the form of suppression or abnormal retinal correspondence or monofixation syndrome. Now, what is suppression? Suppression and abnormal retinal correspondence, they are basically interrelated adaptations to strabismus occurring before 6 years of age. A binocular sensory adaptation that occurs when the patient is using both eyes in the presence of a strabismus to avoid visual confusion and diplopia is a suppression. Suppression is basically a cortical adapting phenomena. In small strabismus, of less than 25 prism diopter, both suppression and ARC usually occurs. And in large suppressions, large strabismus more than 25 prism diopter, the suppression dominates. So basically, suppression is an extension of the normal visual processing. And we all know that suppression symptomas are basically they are in the central diplopia. They call central diplopia. When the strabismic eye fixes, the symptoma immediately disappears, only to reappear when the eye is again misaligned. The shape and size of suppression symptoma are different in esotropes as compared to the exotropes. An esotrope usually uh, exhibits a small round sarcoma that envelops only the nasal retinal area within which the foveal view image is aligned and the eyes when the eye is projected. While an exotropic patient, the sarcoma is much larger and it is in the temporal retinal area on which the foveal image is viewed in the aligned eye project when the aligned eye is projected. And how to diagnose this suppression? Suppression is basically diagnosed with these tests: the Bagolini striated lenses, synaptophore, red glass test, Worth 4 dot test, after images test, and Dazzle test. I will not go into the details of each and every test. Now, how to manage suppression? This involves training the patient to be aware of the suppressed images, then correct integration of the two images, that is using the normal corresponding points so that they do not enforce the ARC. And simultaneously stimulating the normal corresponding points must be carried out when the visual axis cross or by first correcting the angle of the strabismus. So along with the management of suppression, treat the ARC at the same time. First, carry out the accurate refraction to minimize the angle of strabismus and maximize the clarity of the images. So, one or more methods that I will discuss when the management of ARC can be applied for the management of suppression. Now, ARC, what is ARC? It describes a condition in which originally the non-corresponding retinal areas of two eyes cooperate to produce a form of binocular single vision. A shift in spatial localization of the deviating eye occurs to counteract the effect of the ocular deviation. So we all know that there are three types of ARC: harmonious, unharmonious, and paradoxical. I will not go into the details of these ARC, but we should all know that these are the three forms of the ARC. And conditions for the development of ARC are when strabismus appears before 4 years of age, especially before 30 months, when there is a delay in the treatment of the suppression, when there is a small constant strabismus angle, or esotropia is more than the exotropia, or it may or unilaterality is more as compared to the alternating type of strabismus. There are different theories for the development of ARC: the innate theory, adaptive theory, Trevor's theory, and motor theories. Now, how to clinically evaluate the ARC? Many of the procedures used to assess the ARC give varying results depending on the status of the fixation. So, prior to testing the ARC, it is essential to determine whether fixation is central fixation or eccentric fixation. So, it is often necessary to use more than one test to measure the retinal correspondence. So, different tests are there uh, for measurement of the ARC. Now, what are the clinical characteristics of the ARC? The stereopsis is there, microtropia is there. Using a tetanus stereo test, stereoactive or 100x test, these clinical features can be more prominent using random stereo dot stereograms. And in large angle strabismus, when no stereopsis is possible, then the peripheral depth perception can be found. Now, evaluation of the test. How to evaluate the ARC with the different tests. The visual conditions at various tests for evaluating the retinal correspondence are variable. Tests are readily duplicating, so more number of tests should be applied for measurement for recognizing this ARC. So these are the hierarchy of tests in which ARC um, can be there. The Bagolini lenses, the synaptophore, red filter, Worth 4 test, negative after image, and positive after images test. Now, how to manage the ARC? In the majority of the strabismus cases, ARC is considered beneficially for visual confusion and diplopia, and it is therefore encouraged and not to be treated. The exception is if surgery is to be carried out with a chance of obtaining binocular single vision. But great care should be taken as so as not to produce diplopia after managing the ARC. In general, the cases considered for treatment will be of mixed correspondence. Predominantly normal correspondence will recover anyway, but predominantly abnormal has a poor prognosis. So general pattern of treatment of ARC and suppression is first accurate refractive correction, then amblyopia treatment should by giving occlusion orthoptics should be started. Then the prism methods are there for the management of ARC and suppression. Now, what is monofixation syndrome? So many binocular patients who have a small or absent tropia, basically when it is esotropia up to 8 prism diopter and esotropia or exotropia up to 8 prism diopter and vertical strabismus up to 2 prism diopter and possibly superimposed phoria, that is the monofixation syndrome. So it is a sensory state which has both the features of normal retinal correspondence as well as ARC. So these are the few older terms like monofixation phoria, microtropia, microstrabismus, esotropic flick syndrome, or small angle strabismus to this monofixation strabismus. The features of this monofixation syndrome is there is consistence. When it is consistent with normal retinal correspondence, then there is presence of measurable fusional vergence amplitude and there is presence of stereopsis. Relatively stable alignment is there in these patients and there is a demonstrable peripheral fusion in these patients with no measurable tropia in many of the patients. When it is consistent with anomalous retinal correspondence, then small tropia is present in some patients and there is lack of stereoptic appreciation in some of the patients. The clinical manifestation, basically there is absolute facultative or central sectoma that usually measures between 2.5 to 3 in diameter, and likely there is a suppression sectoma seen in the binocular patients who have childhood onset strabismus and large tropias, and it is present only when a given fovea is not fixing. This is the characteristic point of this monofixation syndrome. To summarize my talk, the suppression can be transferred from one eye to the other, probably the initially cortically, but may have a retinal component, then eliminate confusion, and if area extends, then diplopia is there in most patients with strabismus only an early age. In early age, both ARC and suppression are present, and in convergent strabismus, form vision suppressed at the macula and to the nasal retinal point receiving images. Localization of object in space is modified across more extensive peripheral areas of strabismus to avoid diplopia. ARC suppression, they are basically binocular adaptations. Normal correspondence returns and there is no suppression when the fixing eye is occluded and strabismus eye takes up fixation. So monocular syndrome, if present, it should be recognized as early as possible. So thank you very much for your patience.
Thank you very much. Very nicely summarized. This is an important thing. Now we have the last speaker, Dr. Santhan Gopal is on the line, and he will be speaking. He has a topic which is very different. As he is different, the topic is different of amblyopia. Dr. Santhan Gopal, please. Please stay to the time. We are running out of time now by 5 minutes because we have some panel discussion also. There will be a lot of questions people would like to ask. Dr. Santhan Gopal, is he online? Kamil? Acha, sorry, we have a message that Dr. Santhan is not able to communicate. So we stop the session here and we have now questions from the audience.
Sir, I would like to add something to Dr. Rina's talk.
what she said about all
No,
electrophysiology.
let us have first questions from the audience, then we'll
Okay.
discuss. Please,
Okay, sir.
because this is for the audience. So,
Okay, sir.
any questions, Dr. Kamil, Dr. Karamjit will take the questions and it will go to the panelist.
Sir, there are no questions from the audience.
Okay.
Till
So now, okay, Shreya, then you can say what you were saying.
No, I just was saying that I would like to add to Dr. Ina's talk because
Uh-huh.
nowadays whenever we are doing any electrophysiological test, it is mandatory not to use the contact lens electrode. And she rightly said that the skin electrodes are very good, but especially in pediatric, uh, as such contact lens electrodes are not used. But if somebody is using, they should stop using contact lens electrode because of COVID. And Dr. Urmil's talk, I would say that we also had lots of study for levodopa and we published also. And we also noticed that levodopa along with the full-time patching works in our study. It was RCT of 200 children. Thank you.
देखिए ऐसा है कि it's still very controversial. You know, this levodopa has been going for last 3 decades. This, you know,
Yes,
the
sir.
investigations.
Yes.
But you know, it's always there's a pros and cons. There is another citicoline which is now more in the vogue. You know, citicoline. The surveys are marketing now 400 milligram oral dose. That has shown to be quite effective. There is one thing more I expected Urmil to touch on that also. Just for the viewers also and all the people who are listening. Apart from these levodopa and citicoline and all these drugs which have been tried for a long time, now certain newer neurotropic genes have been detected in the brain, in the occipital cortex. You know, the neurotropic agents, what we call it. There have been almost a dozen type of genes, intrinsic factors. What they call is an intrinsic factors. We don't have time to name them, but they who are supposed to act and stimulate the synaptic activity in the brain. So all this is dependent on that. So almost 3 intrinsic factors have been already detected, and there is now a trial going on to manufacture them synthetically and inject them into the brain also directly or take orally to stimulate the occipital, the visual cortex. One question I want to ask Dr. Subhash Dadia. Kurana sir, welcome. आपको कुछ कहना है?
Yes, sir, I must congratulate you for the wonderful conduct of the session. I just wanted to say that for the general ophthalmologist, we should give certain guidelines. What tests he should do in his, he or she in the OPD for when a preschool children comes, because advanced electrophysiological tests may not be available then.
Yes.
So that is very important. And secondly, clear guidelines if we have any use of these pharmacological agents, and if yes, in which condition. No. So that should be, I think, very clear message should go to.
ठीक है. सुभाष, मैं आपसे क्वेश्चन पूछना चाहता हूँ फॉर द व्यूअर से. ये जो डायकोप्टिक ट्रेनिंग की जो स्ट्रेटजी है, do you think it should go simultaneously with the occlusion treatment, or it is after the occlusion treatment when some vision has already come to the amblyopia eye? Subhash? Sir,
my concept is very, yes sir, I am replying. My concept of treating amblyopia is very clear. The first line of occlusion and other treatment modalities, they are adjunctive therapy in treatment of amblyopia. There are a lot of studies which are going on, and the initial results are thing, but primary line of therapy as on date remains occlusion, occlusion, and occlusion. And all these other modalities, they are adjunctive therapies.
Correct. Now for the public sake, you say, what do you think is the cutoff line when the amblyopia, monoocular therapy of amblyopia has stopped working and we go to dioptic? Because dioptic therapy basically is aimed to improve the binocular vision. Because we have about 60% binocular cells and 40% monocular cells in our occipital, the area V1, and therefore ultimately we are trying to also stimulate the stereoscopic, the stereoactivity of the person. So binocular therapy actually comes into that place where we want to stimulate the binocular vision of the patient. So what time do you think we should switch over to dioptic?
Basically, sir, this concept of dioptic therapy has come from the fact that visual improvement with this occlusion therapy is not 100%. So now the changing from mono, the concept is amblyopia is not a mono problem, but it is a binocular problem, and it is because of the suppression, and due to that there is amblyopia. So, but as on date, primary line of therapy remains occlusion, and all these other therapies, they are adjunctive therapies. They should not be tried as a primary line of therapy.
No, agree. But when should it start? Simultaneously or after the vision has improved? And at cutoff line kya hai?
We have done 2 trials, one regarding this television games and other regarding the mobile games, and we have found that the results are better if they are started simultaneously.
Okay.
As compared to the occlusion alone.
Excuse me, Dr. Yogesh sir, I would like to ask the intrinsic agents which you were telling about my talk. Sir,
Your voice is not clear. Please.
जोर से पास आके बोलो उर्मिल.
Sir, I wanted to ask the intrinsic agents which you were telling about my talk. Are they come in the category of pharmacological agents, and is the research work already on them?
Last 1 decade the research has been going on, and as I told you, I mean, a few of them have been already identified, and they're trying to manufacture.
Any particular name? Any particular name?
नाम तो वो GPT G6 है और ये है, और मेरे को भी पूरा भी
हो सकता है, because I searched the entire net. There was maybe there must be. I'll just explore about it. I'll update you. Thank you.
Thank you so much. हाँ करण. अरे यार लेकिन अब तो अच्छा चलो. I think Dr. Santhan has now joined, so but the time we have only 5 minutes now. So Santhan, can you join in, please?
We'd like to listen him also, sir. So many audience will like to listen him.
ठीक है, yeah. Dr. Santhan. Dr. Santhan.
I think the video is stuck.
But actually, see, problem क्या है कि we have a very limited slot. You know,
Dr. Shreya, you were saying you've done the study on levodopa. Kindly get it published because it was not there. Otherwise, I would have definitely mentioned.
I'll surely send the copy to you.
I would have put it in my talk. I would have loved to put it.
Thank you so much. Thank you so much. Dr. Dedia, sir, I just wanted to ask that out of your television and mobile, have you done study amongst them? Which one is better? Because one uses near and one uses distant vision. So, have you done anything for that? Sir, you have to unmute yourself. Sir, your audio is muted.
Unmute करो, सुभाष उसको हाँ या अब बोलो.
So basically, these two theses have been conducted, and we have published regarding role of television games, and we are in the process of publishing regarding the mobile games. But you know that mobile is very common, and I think that is more important.
Dr. Pradyut Sharma is also on the line. आप कुछ कमेंट करेंगे डॉक्टर साहब? अनम्यूट करियो अपने. अब आपको अनम्यूट करो.
About what? Basically about the binocular therapy. I think
binocular dioptic therapy.
It's a good alternative if the starting vision is not very poor. So we have done a study in which we have shown in the APOS also, we had presented in 2019 that it is as good as occlusion, with the benefit that the stereopsis achieved earlier and better in the but this was done in the anisometropic amblyopes, and this is an alternative to occlusion. The only thing is that the presentation vision, that means the starting vision of the amblyopia time, should not be very poor. It should be something like 660 or better, 624 or better.
नहीं, but आपने as an alternative to occlusion किया या simultaneously किया या उसके बाद किया?
That's what I'm saying. Binocular vision is an alternative, but only in cases in which the visual acuity in the amblyopic eye is not very poor. If it is very poor, then occlusion has to be started first to get them to that level.
नहीं, very poor मतलब level क्या है? Audience को थोड़ा ये बताना पड़ेगा.
6/60 or poor is very poor. Moderate amblyopia is defined as vision which is between
624, 636, ठीक है.
624 is possible.
Sir, there is a one question from the audience.
Please.
Dr. Subhash. Dr. Meena Kumari is asking, should we not be refusing surgeries like keratoplasties or cataract in adult patients on ground of amblyopia if it can be corrected in adult patients post surgery? To Dr. Subhash.
Yes. Good question Subhash, बताइए.
What is question?
ये कह रहे हैं कि अगर किसी पेशेंट को एम्ब्लाइपिया है और उसको कैटरेक्ट है और या तो केराटोप्लास्टी करने के बाद इंप्रूवमेंट होगा क्या?
What is the age of the patient?
एडल्ट है, कैटरेक्ट हो गया.
And patient is having cataract and
एम्ब्लाइपिया.
Sir,
definitely it will improve.
Should we not be refusing surgeries like keratoplasties or cataract in adult patients on ground of amblyopia if it can be corrected in adult patients?
If there is indication of the keratoplasty and if there is indication of cataract, then that.
नहीं ये बात तो देखो. See, we already. Number one thing is, see, what is the level of amblyopia? अगर 612 या mild amblyopia 624 vision है और cataract से 660 हो गई है, तो फिर तो आप cataract तो करोगे. You will have to do cataract to improve, to make his vision come back to 612. So that is not the question. After removing the cataract,
amblyopia must be clear.
Hello, can you hear me now? I think I will respond this to the person who has asked the question. You see, if there has been an amblyopia and the patient is a known amblyopic 612 or 618 vision, and by cataract now the vision has gone to 560, you will definitely operate for the cataract to bring his vision back to 612 at least. And then whatever is remaining 612, say you can still try the amblyopia therapy. That is a different.
I think, sir, the sense.
Sir, age is no bar in treatment of amblyopia.
I think there is a confusion. The audience wants to ask, suppose there is a good vision 616 in one eye and the other eye had cataract or corneal opacity from childhood, and the patient comes as an adult. Now we take this eye or not? Yeah. Basically, confusion is this. If the child, yes. That is the main question.
Right, sir.
Will it be useful to do the keratoplasty and patient has come to you during adult age, but
I understand.
childhood.
Dr. Santan Gopal is now logged in.
9:30. Otherwise, there was no confusion. What we have answered to that. Confusion comes in such cases.
I agree. मैं एक half a minute में इसको मैं बता दूं. You see, we all know that amblyopia, there is an age critical period, 3 years, 4 years, 7 years, maximum 8 years. Now, if the child has become blind before 8 years or 7 years, we have chances, we have to tell the patient, and now he has gone into cataract after 50 years of age. Then, the chances of coming back is very meager. That has to be explained to the patient. We can try, but what will be the outcome? We cannot ascertain, we cannot promise to the patient. Am I right, Pradeep ji?
Sir, I think at least keratoplasty should not be done, because if the other eye is normal, we should not do the keratoplasty and waste one cornea, because no useful vision is going to come in this.
Yeah, cataract to kar hi sakte hain.
Cataract, there is no problem in doing cataract any time.
So
secondly, regarding Pradeep Sharma sir's observation, sir, this PEDIC group, they have found these video games not to be as useful as touching. The preliminary results.
They have वही बात उन्होंने बोली कि simultaneously जब भी start कर सकते हैं जब vision ठीक है. If the vision is too poor, then we should not have simultaneous dioptic. First, correct the bad eyes.
Sir, the problem with these games is they are boring, repetitive, and that is the reason.
But अब games बहुत अच्छे आ गए हैं. Games are changing. They are very good games. It is very interesting.
Anyway, I think we have managed the time also.
Yes, sir. Yes, sir. we are running short of time.
Okay, so we close this session. And now I invite the second session, and Dr. Khokar will take over, and Dr. Karamjit will take over. Dr. Karamjit, please monitor the time and this thing. And Khokar sir, please take over the session.
Thank you.
Sure, please, I'll do that.
So I invite.
Thank you, Dr. Shukla. Sorry, can I just go ahead?
Session.
Okay.
Dr. Binakshi, Dr. Samanganesh ma'am, and Dr. Magnine for the second session. Dr. Sudarshan Khokar sir.
Yeah, please. Thank you, Karamjit, and I think I welcome you again. And this is the session now we talk about pediatric cataract. What we thought in this one, we'll go ahead and talk about the indications first, and then we'll see what is the IATS study. So Kalpit, till the time you get you ready. So once Kalpit tells about the indications, when should you intervene for the cataract in these pediatric eyes, then it will be followed by Ramesh Kukunia. He'll talk about the IATS study. Now, in fact, FAKR treatment trial study was one of the biggest studies, and they're still publishing papers over 10 years now. I think Ramesh is going to give us insight how the patients are picked up and what is the outcome, because I think all the resident, everybody should be aware of the studies. It has some plus points and it's got some negative points. I'm sure he's going to touch upon that. After that, Vaishali is going to talk about the eye power calculation in pediatric. I think that is one of the most important topics. I'm looking forward to listen to her. Then I'll tell you where to put the lenses in these patients. I mean, you want to go sulcus, you want to go in the bag, you want to do scleral fixations, and that will come. And finally, Dr. Jagatram will take over and wrap up the session with his talk on difficult situations. So now I think I'll ask Dr. Kalpit to please start his talk. Kalpit, all yours.
Yes. Thank you, sir.
Kalpit, go ahead. Yeah.
Yes. Yeah. Am I audible?
Yeah, you're clear.
Am I audible, sir?
Yes, please go ahead.
Please carry on.
Okay. Thank you. Okay. Yeah. Today I am going to discuss about the different indications for doing a pediatric cataract surgery. In pediatric cataract, the main question arises like whom to operate. So any cataract which is having a visually significant impact, which is more than 3 mm from the central lenticular opacity, should be operated. So in way we can say that any central dense nuclear cataract which obscure the fundus glow, which can be we can check by the distance direct ophthalmoscopy. So any central glow which is obscuring more than 3 mm should be operated. And another point, like if we are observing one eye having a mild lamellar cataract, but if this eye starts showing the nystagmus or strabismus, then this child should be operated now as early as possible. Now the second question comes that when there is we have find out that there is a visually significant cataract, then when should, so normally we try to operate as soon as possible, but here we have to understand the two prime factor. One is like embryogenic factor, and the second factor that is like the anatomical development as well as the general anesthesiaries. So we have to keep the balance between these two. Like if we operate early, then chances of anatomical proper development of eye is not there. There are chances of general anesthesiaries, and if we operate on a later stage, then chances of developing amblyopia is there. So we have to keep the balance. So to answer this question, like we can say that when there is a unilateral visually significant cataract, it should be operated at the age of 4 to 6 weeks. And if it is a bilateral, then we can little lengthen the time and we can operate between 2 to 3 months of age. Now, this situation is different in different types of cataract. Like say for example, here in this screen on right side, type of lamellar cataract, which is not significantly like obscuring the fundal glow. So in that case, we can definitely wait and watch. But if like we can see on left side of the screen, if that lamellar cataract develop and obscure the central fundal glow, so in that case, we have to operate as early as possible. Same with the blue dot cataract. Like on right side of the screen, you can see this type of cataract, definitely we can wait and watch. Sometimes it happens that it remains for lifelong and doesn't need to operate. But on the left side of the screen, you can see some of the blue dot cataract opacities we can find. But if this opacity conglomerates in the central part, and if it obscures the or it develops the amblyopia, so in that case we have to operate. So in normally blue dot cataract, normally like the age of surgery would be around 8 to 10 years. So before that, their child has developed a proper visual stimulation, and after that we operate, we get the better visual rehabilitation. Now another story regarding the anterior polar cataract. Here you can see that central anterior polar cataract, which is having a less than 3 millimeter of the central opacity, definitely we can wait and watch. But here the situation depends whether it is a unilateral or bilateral cataract. If it is a bilateral cataract, definitely we can wait and watch. But if it is a unilateral cataract, we have to keep cautious. Like in that case, what we can do, we can give the occlusion to the normal eye, and along with that, we can also give the mediatric drug. So from the peripheral entering the eye and stimulate the retina. So in that case, we can prevent the development of amblyopia. But regarding the anterior and posterior polar, like posterior polar or posterior lentiglobus is comparatively more amblyogenic compared to the anterior polar because nodal point. So in that case, the posterior lentiglobus or posterior lenticonus should be like observed very frequently. Another story regarding posterior lenticonus, like we watchful about posterior dilations or posterior capsular defect. If there is a posterior capsular defect, and if we continuously monitoring and we see that posterior capsular defect is enlarging, so in that case, we have to do surgery as early as possible. Otherwise, if it remains the same, we can definitely postpone the surgery. Now, regarding the earlier the surgery and the later the surgery, like earlier surgery if we do, the chances of surgical complication would be less. But if operate on a later stage where there is a significant PC defect, then the chances of complication would be more. So we have to keep the balance again between the amblyopia and the anatomical factors. Same like some anterior cortical cataract, you can see some of the spots seeing in the peripheral parts of the lens. So these type of lenticular opacity, just to be watchful, is not required to be operated as early as possible. Just we have to be like wait and watch, continuously follow up, and if this type of opacity can remain lifelong in the same manner. Another type like posterior subcapsular cataract we come across like after the nephrotic syndrome, like after steroid or mild trauma. This type of cataract also, like if the central subcapsular cataract
Frozen. I know.
I think there is a problem with the connection.
It looks like that, yeah.
Yes, sir. Yeah, is it fine?
Yeah, Kalpit, go ahead. Go ahead.
Okay. So regarding the sutural cataract, like we have to be wait and watch if the central sutural cataract dense or if the intensity increase, then and then we have to operate. Otherwise, just we have to keep a watch. Now another type of cataract, this is the different situation, like cataract with the persistent fetal vasculature. Now here again the cataract is very visually significant. It has a very amblyogenic intensity. But here also we have to keep the balance. You can see the cataract is significant, but along with that there is a persistent hyaloid artery. Along with that there is a vessels in the anterior segment. So if this type of cataract having a microphthalmos and microcornea, then we have to be cautious. We have to counsel with the parents that it is a double-edged sword. So if we operate and if we get the hyphema and all other complications, then chances of phthisis could be there. And even if we operate, the surgery goes well, But functional outcome, we all know that this type of unilateral cataract, we can't get the better functional outcome. So we have to counsel the parents, if they are ready to bear the any complication for the long compliance, then and then we have to operate. Otherwise, we can keep this eye as like that. Now, another situation, tricky situation regarding ectopia lentis. If there is a subluxation of lens, bilateral, and the edge of lens, we can't see with the undilated pupil. Just we have to keep a watch. If it is a myopic shift, then we have to give the proper glass and the amblyopia treatment. So in case of bilateral subluxation, we have to keep a watch and just follow up the patient. But this situation would be different in case of unilateral cataract. In unilateral cataract, unilateral subluxation, if we see that is anisomyopia because of the subluxation, so this type of cataract should be intervened as early as possible. So here just I have tried to narrate that different types of cataract would have a different indication and different timing of the surgery. Like this is my view, but panelists can have a different view for the different types of cataract. Khokar sir, thank you.
Thank you, Kalpit. That was fantastic. So you actually covered everything so well. So is Ramesh there now? Ramesh? Yeah, no, before I start that, in fact, the phakia treatment study, I think every journal will have one publication coming over the last 5 to 10 years now. So let's go into the nitty-gritties and see what exactly, and who better than Ramesh Kukunia, who's got a vast experience in pediatric cataract. Ramesh, all yours.
Thank you for having me. I hope I'm audible and the slides are visible.
Okay. Clear, good.
So before we go on to the study, I think we all should know the eye, what we are touching here with the pediatric cataract, has very dynamic. When I say dynamic, in the sense of change in the axial length in the first 2 years and the severe steepness of keratometry changing in the first 6 months. So we are fighting, either it's a aphakia or pseudophakia, whatever it is.
Dr. Kalpit, you have to stop sharing.
Dr. Kalpit Shah, kindly stop sharing your screen.
Yes, sir.
Kalpit. Yeah, we got Ramesh now.
Okay. I hope you can see my slides.
Yeah, we can see you. Ramesh, go ahead, please.
Okay. So I think this dynamic change in the eye, in a child's eye, is very, very important and fundamental before we talk on anything. With regards to infantile aphakia treatment study, there are multiple publications. The study has spanning over almost a decade now. It's a multicentric study from US. It looked at complications, adverse events, and additional intraocular surgery in unilateral cataract. It's very, very important. And the rates of intraoperative complications and adverse events after 1 year and even after 5 years is much more in the IOL group compared to the aphakia group. But their function impact does not clearly favor either group. So this was one of the first studies. And if you see the 5 years outcome, which is published in JAMA, the outcome of that says that there is no significant difference between the median visual acuity of operated eye with intraocular lens and those who left aphakic. But there were significantly more adverse events and additional intraoperative procedures. But for me, the last sentence is very important. The primary IOL implantation should be reserved for those infants where, in the opinion of surgeons, this is very important, cost of handling the contact lens would be so burdensome as a result of significant periods of uncorrected aphakia. And also we need to know the IOL under 2 study, which is a British unilateral cataract group, interest group have done it. I think someone's mic is not muted.
Sumita and Yogesh can mute, please. Sumita and okay. And
Yeah.
Yogesh.
Thank you.
Yogesh, applause. Thank you.
Haji.
Mute, Khalid, please.
So, this is about under 2 years with bilateral and unilateral cataract. Routine use of intraocular lens in this age group cannot be recommended. I think still one mic is on. I would appreciate if it is muted.
Dr. Joy Shukla. Joy Shukla, please. म्यूट कर लीजिए डॉक्टर साहब अपना प्लीज.
नहीं मेरा तो म्यूटेड ही है, किसी और की आवाज.
It's not showing. अब हुआ म्यूट. ठीक है. रमेश go ahead please.
If you take based on age on how to decide, we all know that the comfortable age beyond 12 months, but between 7 to 12 months, many people are comfortable, but the gray zone remains this part where from 2 months or 4 weeks, we generally operate 4 or 6 weeks to 7 or 8 months is the gray zone, what we really need to understand. And also, all of us should know that unilateral cataract versus bilateral cataract, they are very different in terms of ocular or systemic association. In fact, the size of the eye and the angle, everything is different in unilateral versus bilateral. And in our country, we need to remember that this is a typical rubella face. If you look at this face, you need to diagnose that this is rubella. So this is a typical face they will have. And in them, the implantation of lens or whatever is different. And lastly, we need to remember that morphology of the cataract has to be looked into. So all in all, we can't take only infantile aphakia treatment study where age has been taken as one of the single most important criteria. So I have put it on yellow. But there are additional things like corneal diameter, other associations, laterality, intraoperative findings. Because if you find something intraoperatively, you might have to take a decision intraoperatively. Socio-economic status of the child, the parents and the family, surgeon's experience. I think this also plays an important role in terms of deciding what the best care for that child you can give, and also compliance to post-operative care with the child. So what has changed? There are multiple publications from Asia as well as from India. This is one of the 5 years outcome, post-operative outcome in bilateral aphakia versus pseudophakia in children up to 2 years. This is from Dr. Vasavada's group. You can see that the conclusion is incidence of post-operative complication was comparable between the two groups. And the last part is important. The visual rehabilitation is faster in pseudophakic children. So this is one of the things we need to remember. And we also, from our group, we have published the safety profile of primary intraocular lens in less than 2 years. And we suggest that it is safe and can be considered as a viable option. And Chandigarh group have also agreed with this, because I'm sharing there are different publications from different parts of the world. And also we have looked into the infants complications and rate of additional surgery. If you look at one of the Chandigarh group's paper, there was a low incidence of adverse events and additional surgery requirement in infants who had cataract surgery with primary IOL implantation in infant. And also, if you see the TAP study, that's an extension of this study, toddler aphakia and pseudophakia. They have come up with the new finding that till 7 months, it's not a good idea to implant. Beyond 7 months, it could be relatively safe. And we also looked at children in our group at Ali Prasad, looked at less than 6 months, what's the outcome. We found out that in appropriately selected patients, it's quite successful to implant this lens. Before I end, I just want to give a little bit different perspective, because there are affluent, middle income, poor and very poor countries. But if you look at the last row, where the number of blind children are more always in very poor countries. Why this is important in congenital cataract perspective is congenital cataract prevalence, according to this scientific reports publication, is highest in Asia. So whatever has been applied to affluent countries, it may not consider applicable to our countries. And most of the cases are bilateral, isolated, hereditary and total and nuclear in morphology, most of these cases. If you look at the cost factor in IATS, the total cost management was reported to be marginally, that is 5% higher in IOL group. This is because there was higher number of unplanned resurgeries in the first year. And cost management of IOL group this we need to remember, dropped dramatically post the first year. So this is a table I have formed. Our GDP is 7.5 times less than USA. This we need to remember. If you look at the cost of surgery for IOL, aphakia, membranectomy, and the follow-up, they're all in US dollars. You can compare how different the cost in terms of being a different GDP country. And majority of congenital cataract patients are in Asia and Africa. And if you look at the follow-up pattern, we looked at the follow-up pattern observation over a 5-year period. The follow-up significantly drops after first year. You can see both the paying higher economic, socioeconomic status as well as lower. We can see significantly they drop over a period of time. This is also is important. So finally, when you consider these children, what is the best treatment for this child? You can see some are bilateral here, some are unilateral with exotropia, already amblyopia being developed there. What is the best scenario? You can't just toss a coin and decide, okay, this child, I'm going to, this is the aphakia group, this is the pseudophakia group, and implant either lens or contact lens. This is not a real world scenario. In the real world, we need to consider many of these aspects as we have considered in unilateral and bilateral. This is the decision making. I think out of this, if we can take home this message, I think is the most important thing. You need to look at the biometry. You need to look at the ocular comorbidities. We need to look at our own experience. Am I compatible, or should I refer this child to someone else who will do a better job? And intraoperative complications and findings really dictates you to go for IOL or not. It's not just 1 or 2 factors. This is our outcome of 3-year study. You can say the most common complication is visual axis opacification. It is still much less than whatever is being published in the IATS group. And this is the myopic shift and the visual outcome in this particular age group. So our experience has been in less than 6 months, still 45 to 50% of the patients you can implant. It's not 100%. You have to treat the patient. You cannot treat the eye. You cannot treat based on only age. There are other parameters. That's why in selected patients, it's possible to go up to 75% in more than 6 months age infants. So this is the last slide. I will leave it to you to look at the preoperative factors, socioeconomic factors, intraoperative factors. This is, we are just publishing it in as a review paper. It will be available soon. The take-home message for me from this kind of scenario is IOL implantation should be considered even in selected patients less than 6 months. IOL or not to be decided by case-to-case basis, not purely based on age. One must acquire adequate skills before considering. And the last thing is, it's not that if IOL is a must in all children. We need to remember what is the safest option for that particular child. We can't generalize, just decide what is the best case scenario for that particular child. If IOL is not feasible, FAK also is an alternative. Thank you so much for giving me this opportunity. I will be able to answer some of the questions during the panel discussion. I will stop sharing. Thank you.
Thank you, Ramesh. I think that's perfect. So he's hit the hammer on the nail straight away. So whatever happens in the West and how they picked up their patients, it doesn't mean that you extrapolate and start using it, as he said rightly. I mean, there's so many factors: intraoperative surgical skills, the complications, the socioeconomic. I think you're all facing the same. So I wanted to open this Pandora's box so everybody is free to understand this IATS rather than take it on the face value. Great. Thank you, Ramesh. I think question answers will come at the end. So if your surgery is over, you hang around. Right, great. Thank you. So now next I'll call upon Dr. Vaishali. Vaishali, are you there? Vaishali?
Yes.
Yeah, please go ahead, please.
Can you? A very good morning, everyone.
Yeah, please go ahead.
And, thank you, Dr. Shukla. Thank you, Dr. Kokar, sir. After that very nice and stimulating talks by Dr. Kalpit and Dr. Ramesh, Mine might be a little, let's say, little less interesting. But I think one of the very important topics on which IOL, what power, and how do we decide that in pediatric eyes. And I must say that in this topic, I have no financial interest. I think the fundamental premise, we must remember that it's not just a mini version of an adult eye that we are dealing with. And as was beautifully pointed out by both previous speakers, every eye will be different, and therefore the decision of how you calculate and then how you choose that IOL will be little different depending on the kind of cataract, the eye and everything. But the major problems that we face is, first of all, to get a good biometry. Even in the best of institutes with the best of experience and technology, this still is a major challenge. What formulae do we use? And then how do we set the target refraction based on a combination of literature and the surgeon's own experience? I think all of us here would agree that unless you really have some form of a good biometric measurement, keratometry and actual length, it really would be doing injustice to these patients. But again, there is another reality, and especially now in these COVID times where traveling and getting access to different cities, especially far away from your home, may be difficult in the initial phases. Suppose you don't have access to these technologies, then also there are some reasonable alternatives. So any child typically under the age of 3 or 4 years would need an examination under anesthesia for calculating the IOL power. Now this could be done as a separate sitting, but can also be very well done just prior to surgery, provided the institute or the hospital has a library of potential lenses for these eyes. And handheld keratometers are used. I have taken this picture specifically just to demonstrate that it's easier said than done to do a handheld keratometry or an handheld auto-refraction. These are very, very, very technician dependent. And even, for example, people who have been doing it for many years, it's very difficult. So beginner surgeons themselves have to do it on their own before you really rely on your optometrist or your technician. You should yourself master it before you pass it on to somebody else, is what I feel. And if a child is older, and this would for 4, 5 and up, you could also do other investigations like topography or a shine slug or even abrometry, which gives you some reasonable insights which you would not get otherwise. Like I said, if you really don't have access to these, which is a grim reality at least in our country and in our region, then there are these guidelines, rough guidelines, again from the Western world, from Dr. Rupal Trivedi's group, but you could use them as a mean keratometric value if you didn't have access to a handheld keratometer. Now the issue of contact and immersion biometry in these small eyes, well, yes, practically and theoretically immersion biometry is better than contact biometry, because we know that when we perform contact biometry, that compression factor comes in and you get a little shorter actual length. But again here, a practical tip which I have seen and experienced myself many times, that it is not easy to get a good immersion A-scan reading in every child, particularly in these small children below the age of 6 or 7 months, which have microphthalmos or small eyes. So sometimes you may have to, depending on the operator experience, rely on contact biometry as well. But whatever you do, it should be somebody who does this all the time or day in and day out, because this is very, very difficult and very sensitive at the same time. But yes, immersion, if you get good spikes, so seeing every spike reading, all the 10 or whatever number readings your machine takes, should be seen, and only then look at the IOL power rather than just taking the average with one good spike, which sometimes your optometrist might give you. Optical biometry and the swept source OCT now, if you have a child above 4 years, I would always try that. Maybe you get a reading, maybe you don't get, but if you have access, they should be given this chance of undergoing an optical biometry, and sometimes we might find that they do cooperate. So, but this is all obviously only for older children who can cooperate. Now, once you have these biometric measurements, then comes the issue of what formula to be used. And there are lots of papers and there is lots of discussion, including in the IATS and separate studies that have been done. And every study shows different formulas. Somebody says holiday 1, somebody says SRKT, somebody says holiday 2. But I think what consensus has come up generally is that the Hofer Q, which in adult, if you see, attend an adult IOL power, there is this beautiful slide several years old where Hofer Q has been highlighted as a formula for short eyes, and therefore a lot of surgeons directly extrapolate it as being used in pediatric eyes. But it has been shown in most of these studies, including our study, that the Hofer Q does not work well for pediatric eyes, and this is one message I do want to pass on. Other formulas, holiday 1, holiday 2, which is a paid formula, so everybody may not have access, and SRKT, which is found in all biometers in today's date and time, are very, very good. So for us, based on our results that we found that in 100 or close to 120 eyes, there was a huge range of refractive error prediction errors with all formulas, going up to 5 or 6 diopters from -2 plus. But the SRKT and the holiday 2 had performed very well and had the least mean errors. So the Hofer Q, if you can see in this slide, has the maximum mean error. So holiday 1, holiday 2 and SRKT would be my choice. And the other finding that came out from our study, which the other studies are not looked at, we did a personalization of the A constant, or the surgeon's factor, based on your refractive results. The unfortunate fact is that because we do not have extremely precise biometry and because we do not have extremely precise prediction of their ocular growth, even if you personalized your lens constant, went through all this effort of taking 50 eyes and doing all that, it did not make a huge impact on the post-operative refractive error prediction. So in short, use one of these formulas, SRKT and holiday 1 or 2, whichever you can access. And it's okay if you cannot personalize your lens constant for these pediatric eyes, because again, for older children, anybody above 4 or 5 years of age, this is not published. This is purely based on experience from adult eyes and older children's eyes. The Barrett formula now, which is freely available online on the APACRS website, works very well. In fact, we are working with Dr. Barrett to tweak this formula for pediatric eyes. But again, this is only for children where you get an optical or a SPOSI biometry. Now for the aspect of once you have calculated, what do you target? And I'm sure all the experts here sitting in the panel, much more knowledgeable than me, everybody would have their own opinions on this. But we must remember that when we talk about target refraction, automatically it depends on what potential ocular growth you expect. And one of the major factors for this is the age at surgery. So older the child, lesser is this issue of discussion. 5, 6 years and above, you are not really worried about the target refraction as much. It is only in children below the age of 2 or 3 years, and more so in the younger infants, where you don't know what the eye is going to behave like. So in general, every child will undergo a myopic shift. Although I must say that based on our experience, we haven't published this yet, and I would value the panel's comments after the talks, that a lot of these microphthalmic children who are smallish eyes to begin with, they sometimes don't grow or myopize as much as you would expect. You may have set a target refraction of +5 or +6, and then you find out that they still end up, even in their older childhood, with +2 or +3. They don't turn myopic. So this is something where all the experts who have so much data, if we can really put in all this data and come up with some recommendation, that is something which is greatly needed. Grossly speaking, like Dr. Kekune very nicely showed, that the first 18 months or 2 years of life are when your axial length is changing rapidly, and also your keratometry is going to take a dip in the first year of life or so. And there are studies which show that some studies say pseudophakic eyes grow faster, some say aphakic grow faster, then the issue of amblyopia, then the issue of family history of myopia. So all in all, there are two schools of thought. Most people today, I think, believe that some degree of undercorrection should be performed. That means leave the child a little hypermetropic in anticipation of a future myopic shift. Because when we say myopic shift, it is not only the thick glass -6, -8, it is the axial elongation and the retinal problems that will go with it too. So I'm of the school of thought of some degree of undercorrection, but if it's a unilateral cataract, a little older child, and then you have to deal with amblyopia, you may not undercorrect as much. Key point is undercorrect to some degree, maybe 5%, 10%, 50%, depending on the age, the axial length at presentation of that eye and the other eye, and the laterality. Unilateral children, I would do less undercorrection, even though they may turn myopic, because in our country, giving contact lenses, even occlusion adherence in unilateral cataracts is very poor, follow-ups are terrible. So I would undercorrect a little less in a unilateral child. And there are many elegant guidelines, including the ones given by Dr. Eli Dahan's group and Dr. David Plager's group, and then Dr. Rupal Trivedi's group. These are all freely available online and you could use these. We do a percentage-based undercorrection and about 30 to 35% undercorrection for infants is what we normally aim at. Finally, just a couple of slides on which IOL would you implant once you have calculated. Again, this depends on the biocompatibility. My choice and most surgeons' choice today is hydrophobic acrylic IOL, no financial interest, but that's because the material has a good balance of UVL compatibility and PCO rates. Hydrophilic may be more UVLE biocompatible, but then the PCO is still a problem in the real world scenario. And then again, you can think of, since we are talking of IOL power calculation, older than 5 years where the keratometry is stabilized, and if they have reasonable and regular corneal astigmatism, you can consider toric IOL. And I feel it is a very good option, but again, in this very select population. So I think to sum up, we don't know the answers yet, but if you get a good biometry and if you use modern formulae, aim for undercorrection based on your experience along with literature blended, we still get good outcomes, but these children need to be counseled for refractive error and the potential problems that will go with the refractive error, including retinal detachments in the future. And therefore, we need to keep a good tab on their follow-up. Thank you.
Thank you, Vishali. That's perfectly covered. I think you haven't left any stone unturned. Perfect. So we'll come to the question at the end. So very well done, Vishali.
Thank you, sir.
And you can just take the screen off, so I'll screen. So she very nicely covered everything now. There we go. Am I visible there? Am I visible?
Not yet.
Hello.
Not yet.
No, you are not.
Video
Me?
I've shared it already. Ramesh?
Not yet. We can't see your slide, even the screen. We can't see your
screen.
Neither you nor your screen.
Yeah.
Okay, I'll share it again.
Yeah.
Yeah. Yes.
Now we can see.
Is it there, Ramesh?
No.
Yeah. Now,
Yeah.
now it's there.
No. Kamil, yeah.
Go to
Yeah,
the.
we can see now. Yeah.
Yeah. Your slide is on the screen, Sudarshan, please.
Perfect. Thank you. So I think after everybody has stuck to their own task, so I think that's perfect. So nobody's stepping on anybody's shoes. So let me go ahead and do my talk. So my talk is going to be which lens and where to put it. Now, there could be two scenarios. One is the primary doing the surgery and the bag is absolutely fine, perfect. There's no fibrosis, normal anatomy, normal size. You do a ACC, PCC, put a lens in the bag, get away with that. Second situation could be a bag which is there in its position, but it's got fibrosed. It's got a PFP or it's a defect at the back. So you can't put a single piece in these patients. So then your planning will change. Third could be a subluxury lenses in which the bags are not in position. You can fix in some, but in majority you can't. So you'll have to plan that way. Second could be a secondary implantations. You've done a FAK in these patients, left these patient FAK. You might have done it yourself or they must be referred to you from somebody else outside. As Ramesh rightly said, aphakia is a very good option. If you don't have backup systems, if you don't have good IOL power calculation, if you don't have good vitrectomy machines, and you don't have good anesthesia backups and you have to do surgery quick, I think doing a bilateral aphakia is still not a wrong thing to do. So the IOL will depend on the basically on what kind of indication it is. Second, as you said, material, you can use PMMA. We have used enough PMMA in the past. The only thing we realize is they stretch the bag of these kids, because all these kids will not have the bag of the adult size. So we try to put the adult lens into the smaller kids. So there could be a stretching. So that's where the acrylic hydrophobic scores best on all these ones. You can have single piece acrylic and you can have multi-piece. The trick is single piece, as rightly said, has to go at single site only. It is meant for the bag, to be put in the bag, made for the bag. Please do not put into the chamber, into the sulcus, and you do captures. It's not meant for that. It's got specific haptics, optic junctions. It's got a specific size of the haptic, nature of the haptic. Please do not put them for captures. For captures, you have multi-piece. Now, multi-piece, as the name says, multi. You can use it in the sulcus. You can use it in the bag. And you can actually use it for the SFIOLs at the back also. So that's the one which I think everybody should be used to using. And wherever you get a good chance when the rexes are intact, you can go for a single piece. So let's go ahead. So how do you put a single piece? Simple. The tricks are written on the left side. You have to fill up the donut. You've done an ACC, you've done a PCC, and vitrectomy has been done. Always enlarge the section, because do not use a wound-assisted insertion, these ones, because lens might go and dip into the vitreous. We don't want that. Once the lens has gone in, once the anterior lens bleeding has gone in, you just dip it a little posterior from the back, bleeding, so that the anterior tip goes against the back. So you have to have intact anterior rexus and posterior rexus, and always try to insert it as horizontal as possible, not vertical, and then you can dial it. And this is what you want to do. You want to make the plane go down and then take the tip up to go into the bag rather than hitting the vitreous down there. Okay, so now comes the second lens. The second lens is a multiple pieces. As the say multiple, you can use it anywhere. So it's basically meant when you don't have either the anterior, posterior, or either of the rexes not contiguous. It's compromised. Or it's a big globe. It's a big globe, say more than 14 millimeter of a globe if you measure it before surgery. If you can block this lens and make it a part of the bag, I think then it becomes one structure, does not move inside. But here the thing is, you have to need a rex which is about a 5 millimeter. You can put the haptic into the sulcus and put the optic into the bag, which was the trick which Newham's in 91 gave us first time. And when Gimbel started doing it, he started doing the PCC also, and he started pushing it all the way back so that the anterior posterior capsule will fuse in the periphery. This is one video which shows how to put a 3-piece lens. The first video on the left side is showing a lens which is going into the sulcus. This goes into the sulcus. Make sure you rotate your hand while putting these lenses, because these lenses have a tendency to rotate, move upside down. And we don't want these lenses upside down. And before tucking the lens in, you make sure that the haptics are under the iris and not over it. And this is the second one. In this one, the lens was put into the bag, and while inserting the bag, the posterior capsule gave in, and the rexus extended. So in these cases, rather than taking the lens out, you can capture it with the anterior capsule, which was intact in this case. And this is again simple. You just go ahead, push this lens out, and you can do it from both the sides. And that's how you do it. And this is the one in which it's a buphthalmic eye. So you see, this is what is thrown at us most of the time from my glaucoma colleagues, Dr. Ramanjit and Dr. Vinay Gupta. So this is a patient with a cataract. Now what you need to do is do a rexus. Now rexus looks small. It's not small rexus. It's about 5 millimeter, because the eye is big. Then you aspirate this one and do the PCC in this. And once this is done, now see, these are the lens eyes which can actually, if you leave a single piece or a 3-piece lens in the bag, it'll keep rotating. It won't be fixed at one position. So once you've done a good PCC, and then you actually go in and put the lens in the bag. We put this, in this case, we put it in the bag and we did the capture with the posterior one. But nowadays we changed the technique. We put the lens in the sulcus and put the capture with both anterior posterior capsule being fused together, and this goes down, and that's what it looks like. Okay. All right. Now, bag in the lens is a good technique, but the lens is not available freely to us. This photo was taken at LV Prasad when we did some surgeries there, and that's Mary Tasigon, who's premier for this lens. Now comes for the, now when you want to do a secondary IOL, it's a very good idea to do a UVM, and in this case you see there's after a cataract which is thick, and there's a space which is at the back. So this tells you what are the space available behind the iris to you. So this is the video in which I'm putting a 3-piece multiplex lens. This patient is 5 years old, and this was surgery. Patient was phakic, and this was a subluxated Marfan's case. So the thing is, you have to do a myopia. You have to, after vitrectomy, the people has to be constricted. The incision has to be valvular. The incision valvular, air is not going to come out. So this work of injection under the air we published about 10 years back. A big bubble technique is what we call it. And once the lens goes in, you have to again ensure that the lens goes horizontal. The moment you go vertical, you tend to lose the air bubble out and the chamber might go shallow. Then you have to suture it well, and eventually you need a PI in these patients because otherwise they're going to cause a pupillary block. So once this is done, I go ahead, put a suture and do a PI. And once I do a PI, these lenses stay put. Now, what are the issues with these lenses? The problem is you can have the patient as seen in the left side. This is what a 10 years old patient. 10 years back the surgery was done and the patient is absolutely fine. And as compared to the other patient which comes on with the erosion of the haptic coming out. We did a little study on these patients which came for follow-up. We realized that most of the lenses were stable in the angle and not causing much of a problem there. Now the problem basically is that only two sizes available, 12.5 and 13 millimeter. And if you have a sclera which is weak, in which you can't use a scleral fixated, I think these lenses can be tried. The age has to be more than 6 years and there should not be any pass, and the anterior chamber has to be deep. And if your corneal diameters are less than 10 millimeters and more than 12.5 millimeters, these lenses are not to be put. Because if it's big, it will erode through. If it's small, it will rotate and eat up the endothelial cells. Now coming to the new technique, which is not a new one, which we started recently now, about a year back. Now this is a patient which again came in the subluxation and we started putting artisans. Now why artisans? Because the longest studies available in the literature for pediatric cataract are 14-year follow-up on 13 eyes in which the artisan lens was put in the anterior, in the anterior surface of the iris. Now the section has to be 5.2 millimeter. The more important thing is what I'm going to do now. And here we use a methyl cellulose in the chamber or maybe Helon. Now these two incisions which I'm making are the ones which are not radial, but these are the ones which will facilitate me to tuck these lenses properly. Now, second trick is do not constrict the pupil if you're planning a retro fixation of the eye. If the pupil is too small, you always get into trouble. Now this is not an artisan lens. I intentionally use an Indian lens to show you that even that lens works well. Once the lens goes in, you have to rotate into the position where you want to fix it. Try not to use McPherson to hold the lens because you will not get a good fulcrum. You need a good support with the right hand to hold the lens and then you tuck it. I'm holding the lens with the right hand. It's gone under the iris and the moment there's an impression and I just go and tuck it, one, and that's it. And that's enough. And you realize that the one which you put in with the posterior do not open up, get loose that frequently than the anterior one. Now the other side also. Now see, I'm using the hook to bring the lens onto my forceps and going under it. And again pushing it against the iris and you go it and that's about it. You want to do a PI, not to do a PI. We've done about 50 patients in the past without PI, then there was no rise in pressure because the lens goes upside down in this and does not have a pupil block, and that's what it looks like in the end. So this might be a future in case you want to do these cases. Now the problem with the iris flaw is, the good thing is that it has a long history. Simena et al. Has done lots of work on this one. Now putting the anterior one will take the anxiety away from the corneal surgeons also because they are not very happy with these lenses in the anterior chamber. So even in the smaller eyes you can do it. In few early patients, especially when the anterior one, we had people which were oval, but now with the expertise which we have got now, because I think for the last 1 year ovalization has gone down. Declination was seen more with the anterior fixated ones, and there's a study which is going on which is comparing with both anterior posterior. Will come out with that later. Now coming for the SFIO, which according to me is basically more of a blind procedure. So what we do here is that we mark it on the surface, and this was the patient which is faking. And you mark it and go ahead. I have time left, so otherwise I can go fast with this one, and we have some time. So once you mark it, the important thing is not the glue which works here, but the tunnel which has just created a tunnel. This is a tunnel where the haptic are going to go inside and going to keep the lens. There's so many techniques people have decided for this also, but the most important thing is that marking which you do, where you do, is the most important. That will ensure that the lens stays in the center. And more than the glue, it's the tunnel which you make. And once you go inside, it's like a handshake technique. And here I'm doing a little vitrectomy because sometimes I find that the base of the vitreous which is still intact anteriorly, and it causes a problem when you pull the lens out and you might be causing a traction onto the vitreous. So do a good clean vitrectomy here, take out all the tags which are gone. And this is a 3.2 incision, and the lens is a 3-piece, which I mentioned, multi-piece, can go anywhere. I think that's one of the beautiful lenses which are made. And once the lens goes in, you rotate the lens in, and once the lens comes, you take a forceps in the other hand. And this is a standard technique. I think everybody's following it. You can burn the tip off and you do Yamana's technique, whatever suits you. But most of these patients are so poor, when come from poor background, that they can just afford the lens. So rest, if they can't afford the glue, we can just put and suture it up. So once both the sides are in, we can ensure that equal amount of haptic has been tucked into the tunnels which we created. And then you remove the viscoelastic to the front, put a suture there, and that's about it. So this has to be avoided in patients, especially Marfan's and Beals and autoimmune disorders, because sclera is not normal. Now we started doing a study in which we're doing a swept source OCT measurement of the sclera, and we're seeing whether that scleral thickness is same as a normal. But we realize that it's on the lesser side, but we are still in the process of finding it out. And explosions can be seen. So if this is a patient which is done somewhere else, and this came out with the whatever tunnel was created, it has eroded through it and come in the anterior. So I think less than 6 years we can avoid using this lens. And for other ones, I think if the sclera is healthy, you can work with that. So to conclude, a single piece is always meant for the bag to be put in the bag. Multi-piece can be put anywhere, as I told you. PMMA lens can be used for the patients who are poor, but please go for the smaller PMMA 5.25 optics, not the 6.25 into the bag, because these bags are smaller. Multiflex lens has got a bad reputation, but it's basically the sizing which is the issue. And if the sizing is right, you can use it. We did in a study in patients with subluxated lenses published in Eye about 3-4 years back, and all these patients have followed without any problems. The only issue is the sizing. Artisan iris inclination is, I think, again coming back as a way to go. Anterior or posterior to the iris, where you're comfortable. And thank you very much. So that's it. So, am I there? Karanjit?
Yes, sir.
Yeah, okay. So now I think this is over. I think the last speaker is Dr. Jagatram. He's on. We can take him up and then we can have a question or session.
Yeah. Good morning. I am thankful to SPOSI and Punjab Ophthalmological Society for giving me this opportunity. Special thanks to Professor Sudarshan Khokhar, President of the SPOSI, and Dr. Yogesh Shukla, who is the Secretary of SPOSI. And also I can say so many my friends, Professor Pradeep Sharma, Professor A.K. Kurana, Dr. Ramesh Kakunia, Dr. Vaishali Vasavada, and others. I will be speaking on management of complex pediatric cataract surgery. And these are all such as PHPV, double crystalline lens, posterior lenticonus, uveitis, and other. The first case is a posterior 2-year-old child with the posterior lenticonus, and this picture was intraoperative. Continuous
Sorry, video is not here.
Capsule.
Video is not shared. Please share your video.
Okay.
The green tab there, just screen.
You're seeing a screen, but the video has to be on.
So, yeah, resume. I think it was shared.
So there's a green tab there.
Yeah, green is there. Share the screen. Yeah.
Yeah. Share screen. Please do that. Yeah, that's it. Go ahead, please.
Now it is fine.
Fine.
Perfect. Perfect.
Yeah, because thoda sa. Okay. Okay, go ahead. So first of all, I will show you the posterior lenticonus. This is intraoperative photograph video of 2-year-old child with posterior lenticonus, continuous curvilinear capsulorhexis, approximately 5 mm, followed by hydrodissection and removal of the cortex from the capsular bag. And you can see here loose posterior capsule. So it is must to do primary posterior capsulotomy in such a situation. Here there was implantation of the IOL was done, and then triamcinolone assisted anterior vitrectomy was done because there was a lot of vitreous. So this is the posterior capsulotomy. Here is another child, which is 4-year-old child with posterior lenticonus, staining of the anterior capsule, and then the continuous curvilinear capsulorhexis, removal of the cortex from the capsular bag. You can see here IOL is implanted before primary posterior capsulotomy. IOL in the bag, and you can see this posterior lenticonus, and now performing the primary posterior capsulotomy. The size of primary posterior capsulotomy was kept around 3 to 3.5 millimeter. Here is this child, which is this video seen by majority of you with the double crystalline lens. I am showing a very small video. Continuous curvilinear capsulorhexis on one side of the double crystalline lens, and then now other side, then removal of the cortex from the capsular bag, and then the IOL, customized IOL, customized big IOL, where both the haptic were placed in the bag, and you can see the final picture. And this is amblyopia therapy initiated for this child, and he could see with the operated eye, and he could also catch even the smallest objects. And this picture is old, and this is another patient with high corneal astigmatism with the zonular cataract after staining of the anterior capsule, and here is continuous curvilinear capsulorhexis. Size of the rhexis approximately 4.5 to 5 millimeter. Callisto is used in this. Marking was done before. Removal of the cortex and filling the bag with the viscoelastic. Toric IOL placement was done in this child. Here this is the marking with the Callisto, and this is the final alignment of the IOL along the axis. It has to be absolutely accurate. One may place even a small suture at the end. And this is a child where there is a AIA with uveitis with complicated cataract, small pupil. So here we used Malthusian ring. Now at present also we can use even Bhattacharya ring. So this size of this gives adequate size of the pupil, and after staining rhexis completed, and now removal of the cortex and then implantation of the IOL in the capsular bag, and removal of this Malthusian ring, performing small peripheral iodectomy because this was recurrent uveitis. And here is lenticular coloboma, 4-year-old child with high astigmatism. Here we made the scleral flap. Posterior synechotomy was done. And this is completion of the rhexis. And after that, capsular hooks were placed. Removal of the cortex from the capsular bag. And then this is for fixation of the segment. This is a Sioni ring, single eyelet. For centration of the capsular bag. This is toric IOL, which is implanted into capsular bag here, and removal of the cortex, and this is removal of the capsular hooks, and this is the final, almost final picture. So this is the final picture before and after surgery with the perfect centration of the IOL. And while my time will be over, I will be happy to stop. This is probably, I think, last case I will show, and then I will stop. This child with ophthalmos, glaucoma procedure was done with tube. Pupil was small, and this Malaysian ring was placed, and cataract surgery performed, and this is removal of the cortex from the capsular bag, and this is the implantation of the IOL in the capsular bag, and then this removal of Malaysian ring. And we also thought that this tube is long, so this tube was shortened here, and removal of the cortex. So I am thankful to SPOSI for giving me this opportunity, because I don't want to exceed my time. Thank you very much.
And perfect. You've seen how the masters work on these cases and the master D surgery. Can you, if you remove the share video, that'll be fine. So I think we are open to questions. We got about 7 minutes left, so we can open the questions. Any questions from the panel? Dr. Jagatam, please, you can remove the screen. Yeah, that's good. So any questions? Karamjit, anybody has a question?
Yes, few questions by the audience, sir. So first question is Dr. Kamaljeet Singh. So what are the results of surgery without IOL in bilateral cataracts in a year-old or less, in 1 year old or less?
I think Ramesh had mentioned that it's as good as if it's a bilateral cataract. If you 1 year, it will be as good if you have a good follow-up and the glasses patient's wearing properly. Ramesh, you want to add on anything to this?
Yeah, I think it's absolutely fine. The results are quite good, even with that. Bilateral cataract, it won't make a. But only thing I will add is that the spectacle renewal rate in a child less than 1 year is quite frequent. If there is a compliance to the spectacles, they do very well. No issues.
Perfect. Perfect. So what is the second question, or we can take more questions if you can hurry up, Karamjit?
Yes, sir. If a premature child develops total cataract, we scan normal, how early we can operate? ROP evaluation monitoring has to be kept in mind.
Yeah. See, I think that's a good question, because we get lots of patients for ROP which have to be operated within less 1 month of life. Otherwise, if we don't operate, they'll go blind, because the ROP has to be handled. So it all depends on the team of your anesthesia people. If you have a HUD, which is in which you can take these kids which are even 33 weeks or 34 weeks, you can go ahead. But in these ones with the ROP, you have to do it ASAP, as soon as possible, at stability of the child. So it all depends on the team which you have. If you don't have that, it should be sent to the higher center. Don't wait for these patients, because more than anything, they'll go blind eventually, because the retina issue has to be handled.
Can I add one point?
Yeah, please, who's that?
It's Sumita here.
Please, Sumita, go ahead.
No, sorry. I just wanted to just add one thing to ROP and cataract. I think the somebody from retina department should be there on the table to do a good evaluation of the fundus also after the cataract.
Of course. Yeah.
Sometimes that part gets left behind. Cataract gets done, but ROP is left.
Yeah, I agree with you, Sumita. We're doing the ROP basically to clear the media for the retinal guys. So I do it on their table actually. I go remove the cataract, and I don't even put a lens. I just go with the 2 MBR openings, and that's good enough for them. So if they want to do a surgery at the back, or give an intravitreal, or what, they do that. Yeah, we do that.
Can I raise a point, Sudarshan? Sudarshan?
Yeah, please. Yeah, please.
Here.
So be to the point, sir. We can take more questions then. Thank you. Please go ahead.
How often the parents of the child undergoing the cataract surgery or assess? For example, if both the parents are myopes, the chances are child will become myope.
Of course.
So we can assess the IOL we are going to put in the child based on the parent refractive status.
I'm coming to that. So I think most of the setups, even Ramesh will agree. We always assess both the parents. We in fact dilate the pupil and look for the cataract if it's there. In fact, we can pick up more of Nance-Horan syndromes that way. And we take the refractive error of the parents and the excellence of the kid into consideration, and the age when we decide for the IOL. I think that's a good question, but yes, family has to be taken into consideration. Any other question? Yeah, Ramesh, please.
With regards to ROP, I just had a point. If somebody sees a very plus sign with the iris neovascularization and things like that, it may be a worthwhile to give an injection intravitreal bevacizumab. It's a possible thing if it is so aggressive.
Of course, and in fact you can give it intracameral also and wait for 1 or 2 days and go for the surgery.
So there is one question to Professor. One question to Professor Jagatram, sir. Would you recommend hydrodissection in posterior lenticonus?
One has to be very careful while doing these posterior lenticonus. If it is very extreme lenticonus, then sometime it may rupture during hydrodissection. The case which I did, it was not so where I did some limited hydrodissection. You are absolutely right. In extreme one, no need to do hydrodissection.
Yes, sir.
Right. I'll ask a question to Dr. Jagatram. Dr. Jagatram, sir, you showed 2 videos showing Malugan. In the first one, there was a sphincter which got torn. The iris was small and it was immature. The second one, the pupil was absolutely round. So, and first one had a membrane. So, do you recommend that we should remove the membrane before we put a Malugan in these patients, or you can go ahead and put it there?
I think if there is a posterior synecdoche and or there is a membrane, it is first advisable to remove the membrane and do the synecdoche, and then otherwise this Malugan will not do its job. So it is better to remove the membrane from the which is there between the iris and irole lenticular adhesion. So that has to be done first.
Right, sir. Because in the first patient, first eye, there was a little membrane which was around the margins, which was at the end also, and the pupil was not round. It was cut off.
I agree. We have to remove that, do synecdoche or remove the membrane.
Ramesh, you had a Malugan talk with Boris yesterday, and everybody is all gaga about the Malugan. I still go for the iris, so I think MSc works wonderfully well. What's your take on that, Ramesh?
We did a survey as well. In spite of that, it's expensive. It's an expensive thing. Everybody cannot. And I think, in my personal opinion, in the Grishaber hook works very well for many of these children. So it's not a must, but it's always good to have options. And we did a survey. Majority were going for this. And Dr. Coker, you said that whenever there is a membrane, sometimes in a rubella cataract, we can't even put this hooks. We might have to go for pupilloplasty. Very rare cases.
Yeah, but we do that. Absolutely right. So I think, thank you very much, and everybody is to the point. Any other question left, or we can give it the podium over to the next.
We have to close the session now, Sudarshan.
There are no more.
Okay, I'm asking. Okay, please go ahead. Take care. Thank you very much. Thank you very much, the cataract guys. I'd like to say thanks to Ramesh, to Vaishali, Dr. Jagat, of course, and Kalpit, and thank you very much, guys.
Thank you.
Thank you very much, Dr. Coker. Now we go to the next session number 3, which is basically strabismus. And we have Dr. Amitava, Dr. Surendran, Dr. Ankur, and Dr. P.K. Pandey on the panel. And we have the speakers, Dr. Birsen Güekwit from Turkey. She's associate professor in one of the medical colleges in Turkey and a regular participant in our SPOSI sessions. Welcome, Dr. Birsen from Turkey. Then we have Dr. Fatima Yulek again from Istanbul. from Turkey. She's a professor there in the medical college. And we welcome you all, welcome from SPOSI. And then we have our own Pradeep, Dr. Pradeep Sharma. He needs no introduction, past president of SPOSI. And then Professor Kamlesh, past president of SPOSI, and Dr. Rohit Saxena, another very eminent, promising, budding strabismologist from All India Institute. So we start the session now with first, I call all the panelists on the screen, please. And the first topic is infantile esotropia, types and management, Dr. Birsen Gökikit from Turkey. Dr. Birsen, please.
Oh, hello. Good morning. First of all, I thank the organization committee for their kind invitation. My presentation, as you say, infantile esotropia, types and management. In 1961, Kostanbader described type of deviation, which had a very large angle esotropia with limitation of abduction and almost equal visual acuity in both eyes and small or moderate hyperopia. Later, von Norden added the term of essential to emphasize the obscure etiology.
You might want to share your screen, Dr. Birsen.
Oh, excuse me. I need to turn back. How can I do this?
At the bottom, ma'am, you have an option of sharing the screen in the green.
Oh, yeah. Excuse me. Again. I need to.
Yeah, now it's okay.
And now we can see.
Begin again. I need to get a little larger screen.
You can continue from here itself, no problem.
Okay.
You can make it F5, ma'am. Yeah.
Okay.
Yeah.
I talk about the Kostanbaders and their introduction and von Norden's edition. And clinical characteristics of infantile esotropia are evaluated under consistent findings and variable findings. Consistent findings are onset from birth to 6 months and large angle esotropia, alternation with cross fixation, stable angle which may increase with time, very early fixation preference, no clinical appearance central nervous system, asymmetrical optokinetic nystagmus, low or moderate hyperopia, and accompanied motor abnormalities. Variable findings are amblyopia, apparently defective abduction, excessive adduction, up or downshoot on adduction, or patterns and DVD, DHD, manifest latent nystagmus and anomalous head posture. Types of esotropia is of the one of the well-known Ciancia syndrome. Ciancia syndrome shows very large, over 60 prism dioptry isodeviation with cross fixation and remarkable bilateral abduction limitation in which both eyes appear to be stuck toward the nose. Nystagmus on attempt to abduction, not to adduction. Early onset esotropia with other clinical characteristics in infantile esotropia, but more dominant to show dissociated vertical deviation, named as lung syndrome in European literature. Babies with infantile esotropia most of the time are normal in both neurologically and general health, but needs more attention about associated pathology as Down syndrome, hydrocephaly, albinism, and cerebral palsy. Frequency is 0.1 to 1%, and prematurity, low Apgar index, cerebral palsy, paraventricular malady, and family history are the risk factors. Congenital esotropia observational study, multicentral cohort study about newborn. Inclusion criteria and study protocols seen on the slide. And their results shows that infantile esotropia groups results have a bad prognosis for final result succession. Now I will talk about clinical features. Cross fixation is common, often due to the stiffness in medial rectus, fixative eye captain adduction. Has a head position, If there is alternation, amblyopia risk lower than non-alternative case, but not fusion. Amblyopia is common in non-alternative cases, but has good results into patching. Lateral gaze restriction due to doesn't attempt to abduction or medial rectus stiffness. Inferior oblique overaction seen 70% of the cases, generally bilateral, but maybe asymmetric. Dissociated vertical complex is also very often. Reasons unclear. It's not apparent before 18 months. It can be bilateral but asymmetrical. More prominent, the amblyopic eye. It can develop even if surgical treatment is performed. Not early surgical preventive for this condition. Nystagmus is latent nystagmus. Manifest and latent nystagmus is seen in 90% of the cases. In a pathology that negatively affects binocular development in first to 6 months, nystagmus occur with the closing of one eye, fast face towards the fixing eyesight, abnormal head posture to find the point to decrease nystagmus and increase vision. If there is nystagmus, surgical results are more unsuccessful than those without. Amblyopia percentage is 30 to 50. If there is cross fixation or alternative fixation, the risk of amblyopia is somewhat reduced. Responds well to patching. Monocular processing deficit occurs in every baby in the first 6 months and disappear after 6 months. In infant esotropia, goes for lifetimes. Asymmetric optokinetic nystagmus is normal in first 3 months, but pathologic after 6 months. When we come to differential diagnosis, esotropia recognized easily with cover-uncover test. And cranial nerve 6 palsy actually is very rare in childhood and has a good course with healing in 3 months spontaneously. In favor of inferior oblique overaction, latent nystagmus, and DVD in infantile esotropia are not seen in the 6th nerve palsy. During retraction syndrome also differentiates easily with palpebral feature narrowing and globe retraction. Accommodative esotropia reduces or improves with glasses, and also there is no DVD and latent nystagmus and seen after 6 months of age. Nystagmus blockage syndrome, nystagmus is manifest in diminished by convergence. In these babies, primary defects in neurologically sourced. Sensorial esotropia has also confused the examiner from time to time. But it can easily be differentiated the others. There are many clues both in history and examinations. The rules for achievement are early diagnosis and early treatment, patching if needed, and finally, proper surgery in proper cases for perfect results. When planning the treatment, it should not be forgotten that every child whose eyes are not aligned by 3 months of age should be given complete ophthalmological examination, otherwise it may cause severe damages like irreversible sensorial anomalies, secondary change of extraocular muscles and surrounding tissues, and may develop secondary amblyopia or miss, very importantly, other important reasons like retinoblastoma. Non-surgical treatment is directed toward the correction of significant refractive error, chemodegeneration in certain circumstances, which in our clinical practice we prefer in large indication. And at last, surgical alignment of the eyes are the steps for treatment planning. Of course, restoration of single binocular vision in the practical field of gaze in our goal of treatment with orthotropia, normal visual acuity, normal stereo acuity, and stable sensory and motor fusion. But in some cases, we comply only to improve the cosmetic appearance. Prescribing classes preferred only if there is high ACA ratio and high hyperopia, in addition infantile esotropia. And some authors like to prescribe prism for prism adaptation previous to operation. Surgical alignment timing evaluates three headings: very early, early, and late. While early and very early treatment have advantages for giving high binocularity potential and preventing the contracture, but also have measurement difficulties, miss spontaneous progression time, and higher reoperation risks. Final report of Alice, which is a controlled prospective multicentral study, showed similar results between each group, except in better stereopsis in early operation group and slightly better reoperation, but a high spontaneous regression rate in late operation groups.
We'll have to sum up in 1 minute, Dr. Pearson, please.
Okay. Very early operation advice for babies who has a stable deviation over 40 diopters and before 6 months of age. While operation indications are similar in strabology community, operation choice and preference does change from the continent to continent, country to country, école to école, even surgery to surgeon. My preference is are shaped according to the baby's findings and patient's parents' attention. I prefer early treatment normally in bimedial intervention, often post-op visit for following visual acuity and change of deviation amount. If I don't like to parents' attention or if there is a restriction for the long-standing anesthesia, I perform bimedial Botox injection with Mendoza forceps without EMG guidance and follow them without routine visit afterward. Post-operative management are universal, trying to restore the normal or subnormal binocularity, preventing amblyopia, and performing reoperation when needed. Thank you for your kind invitation again and for kind attention for all.
Thank you very much, Dr. Pearson. It was a pleasure to have you with us from Turkey. Have a nice day. Please remain on the panel because there could be some questions for you. Then the next we have Dr. Fatima Yulek again from Turkey, a professor in the Medical College at Istanbul. Dr. Fatima Yulek should be speaking on oblique muscle surgeries. Dr. Fatima.
Can I say something?
I will about oblique muscle surgery and general principles.
Yeah, please. Okay, fine.
Okay, there we go. Inferior oblique surgery is a relatively forgiving surgery, but we should be careful for peculiar anatomy and the functional differentiation between anterior and posterior fibers. The close relation to the vortex swaying poses special risk during surgery technically. The insertion may be multiple, and we should be careful for this to increase the success of surgery during inferior oblique surgery. There are several weakening procedures. The general indications can be summarized as V-patent strabismus with inferior oblique overaction, primary inferior oblique overaction, then plus 2, dissociated vertical deviation, superior oblique palsy, and excited torsion. Weakening or changing the function of inferior oblique, there are several surgeries. In fact, started from myectomy, tenotomy, myotomy, recession, anteriorization, and inferior belly transposition, anterior nasal transposition, and extirpation with or without denervation in extreme cases. Like most surgeons, I usually proceed with inferior oblique recession. It's a reversible surgery, and it can be asymmetrically applied in case of bilateral asymmetric cases. And there are several surgical dose tables and some simplified surgical dose tables also. The problem with recession, when you do with 8 to 10 millimeter recession, is in fact you're 1 millimeter anteriorization. Therefore, we should be careful in unilateral cases in order to prevent anti-elevation syndrome. Inferior anteriorization is another powerful surgery. Wright has described graded anterior transposition according to the amount of inferior oblique overaction. When compare surgical interventions for correcting vertical strabismus superior oblique palsy, a Cochrane-based review has revealed that there are few studies because of small number of participants and low quality of evidence, and most of these studies are not reliable because of the low evidence and low number of participants. Therefore, the surgeon can decide the kind of surgery that he is familiar with and experienced, and also the clinical situation of the patient. New compartmental approaches can also be tried in these patients, as our colleagues Gökyiğit and also Kushner has described. Posterior anterior fibers of inferior oblique can be elevated for hypertrophy. Also, for V-pattern inferior oblique belly transposition can be tried. So there are some difficulties with the surgery. Some complications are residual inferior oblique overaction if you don't notice the insertion anomalies, and also fat adherence syndrome and inferior oblique underaction are not rare. If you follow the patients for a long period of time, also observe anti-elevation syndrome in these patients. When you do anteriorization, especially in unilateral cases. Luckily, we rarely observe scleral perforation and mid-valgus problems. Superior oblique muscle, as Von Graff stated previously, is sometimes a difficult muscle to approach. We usually avoid it because of some problems with the superior oblique. The anatomy and the possible complications that are hard to reverse. Because this is not a forgiving muscle as opposed to the inferior oblique muscle. The strengthening features, superior oblique tuck, and precision.
Please bring the microphone close to your mouth.
Can be used. Pardon me? Okay. During surgery, superior oblique traction test is useful. If there is laxity in the superior oblique muscle, superior oblique tuck can be added. But the low-hanging fruit is inferior oblique midterm is most of the time, or inferior oblique recession, if you don't want to interfere with this muscle. Superior oblique tuck is a surgery that aims to eliminate the hypertrophy and excited torsion in primary position and in down gaze. It's usually indicated in marked superior oblique underaction with or without, without inferior oblique overaction if the excited trophy is less than 4 degrees. There are many problems with superior oblique tuck surgery. The surgery should be quantified, and there may be problems of undercorrection or overcorrection. In fact, iatrogenic syndrome is usually inevitable, and sometimes in the initial days after the surgery. But there are alternatives if you want to cause problems. Adjustable strengthening of posterior fibers, as described our colleague Gökyiğit, can be used. Or other muscles, as described by Kushner, for NEP2 superior oblique paralysis, nasal transposition of ipsilateral inferior rectus combined with restriction of contralateral inferior rectus can be used. If you want to increase the intorting action of superior oblique muscle, Harada procedure can be used classically or with pulse modification. Weakening posterior depressor fibers of superior oblique can be done with superior oblique posterior tenotomy, especially for patients with bifoveal fiction. It's the procedure of choice. But there may be problems with other oblique surgeries like hemorrhage and undercorrection sometimes if you fail to identify most posterior fibers during the surgery. In positions like superior-oblique myokymia, we can use superior-oblique tenectomy, but we should be careful, especially in patients with bifoveal fixation. Because of torsional diplopia as a result of complete superior-oblique palsy, for posterior tenectomy and anterior tenectomy may be tried according to the hypertrophy or cyclotorsion of the patient. But superior-oblique palsy is, the palsy rate is very high with the surgery, between 50 to 80%. While maintaining some intorsion, weakening the superior-oblique muscle can be done by superior-oblique tendon spacer surgery. It can be done with silicone retinal buckle or non-absorbable sutures. The problem with the silicone is adhesion of the silicone and limitation of depression by adherence of the silicone. Therefore, superior-oblique split tendon lengthening can also be used, but this surgery is technically challenging since you are suturing half of the tendon. But the other problems may be less with this surgery. So take-home messages. Magnitude of the deviation and incompetence pattern usually determine the number of methods that we are operating. And we should address the torsion while choosing muscles to operate. And compartmental decision is in fact very valuable in this by working with these oblique muscles. And we should always be cautious with manipulative using patients do not cause problems, especially superior initially. Thank you for your I'm done. Can you hear me?
Can't hear you.
I think her video got freezed. I think we lost the connection, I guess.
I think connection lost.
Yeah. Thank you, Dr. Fatima, for your nice presentation about the obliques. And our next talk is by Professor Pradeep Sharma, and who is the master of the squint. He'll be talking on transpositioning muscle techniques and the problems associated with it. So next talk is by Dr. Pradeep Sharma, sir. So please come on the panel and start your screen sharing. Dr. Karamjit, I think we would like the administrator to shift the speaker's view to Professor Pradeep Sharma's view.
Yes, sir. Yes, sir.
Is it done?
Kamalji, can you shift the
Is my screen shared?
To Dr. Pradeep Sharma?
I think it's still stuck with Dr. Fatima's screen, so I think the administrator will have to change it.
Mr. Kamil, are you there? I think we need to change the view from Dr. Fatima's view to Dr. Pradeep Sharma's view.
Ankur, phone, I think Kamil, he's not active at the moment. In the meantime, if there are any questions.
Yeah, in the meantime, I think we can take up some questions. And Dr. Karamjit, are there any questions?
No, sir, there are no questions from the audience.
हाँ बोलिए बताइए.
Asking Kamal to hello.
नहीं address to whom?
Okay. Ketan ji, can you assist? Ketan ji,
I'm trying to stop Fatima's screen, but it is we are unable to do.
I think there is a problem with Dr. Fatima's.
Can you just make her exit the group if it is not, if it's just hanging? Is it possible then she can rejoin again?
Yeah, we are back onto the main screen. So now I think if Sir
Now I think
shares the screen. Dr. Pradeep Sharma, you can share your screen, I think.
Sir.
I'm sharing.
Yeah.
Yeah, we can see,
Yes,
sir.
sir. Yes, sir.
Yeah.
And I'm audible, right?
Yes,
Yes,
sir.
sir.
Yes, yes. You can start, Pradeep ji.
Yogesh, I think we need to congratulate you and the Punjab Ophthalmic Society for making this dream realize that we can have a webinar on the web. So that's wonderful that we are having this midterm on the web. Thank you so much.
Welcome. Welcome.
Here's the ball.
Even the football is
He had the
played.
distance and right in the corner of the net.
So we have to change our goalposts. And as we know, we are not just treating strabismus, but we are restoring sight and stereopsis by restoring alignment. And mind you, remember, even in the adults, if there is a duration of more than 1 year of misalignment, it can lead to deterioration in the binocular vision and stereopsis. So let's look at this girl. She has a left lateral rectus palsy with the face turned to the left. She has an esotropia and a limitation of abduction. If the eye crosses the midline, we can get away by doing a recession, resection, or instead of resection, a ligation procedure. And whenever we do a recession, it's preferable to do an adjustable procedure. The plications are a good alternative which have come up, and especially in transpositions.
Oraya yazı yaz bak ben gruba yazayım Fatma'yı tekrar hatırlamıyorum.
Can we have muting of the other people, please?
Yeah, yeah.
So, like this video is there on the net. Any of you, if you want to have a review at it, you can see this is a very nice procedure which has now come up. And in addition to the transposition, if we have to do the third muscle, application is a very good alternative as it saves the blood supply for us, and it can easily strengthen the muscle which has some power. But of course, if there is no power in the muscle, then we will have to do a transposition alone. There has been an evolution in the transposition procedures. The first, of course, was the Hammersheim procedure, in which the half of the width of the vertical recti were transposed to the paralytic side muscle, and in this way we were saving the blood supply. But since the force of half the muscles was not good enough, Scott Foster suggested a posterior fixation augmentation which can improve the force, as you can see in this. And in this girl, we did that. These are the pre-operative pictures of this girl, and you can see the post-op, the esotropia has been corrected, as well as the abduction has improved substantially. But the problem with the Foster sutures is that it may be a non-adjustable procedure, and so you may have an under or over correction. You may be lucky if you are having a little bit of under or over, but if it's more, it can be a problem. So we need to move to the next step. This is a video of the split VRT, which you can see. Basically, what we are doing is splitting the vertical recti, saving the blood supply of the rest of the segment of the muscle. Up to about 10 to 12 millimeter, you need to separate. You may add a resection component in the part of the muscle which you are separating. Pass the vicryl sutures, 60 vicryl sutures, 2 interlocking bites in the half of this muscle, and bring it to the side that you want to shift. This is resected, and we can bring it to this side. Here, similarly, the inferior rectus segment would be moved to the missing muscle, and we can correct that. But if we have a cross section to be done, this is going to be showing you what we nowadays do after the closure. This is the cross section split VRT, in which bring the superior and the inferior recti on the upper and the inferior end, that means reciprocally. And as you can see in this schematic diagram, the superior part has been brought to the inferior end of the parietic muscle, and the inferior rectus part has moved to the superior part. This adds to the vectorization force, and without having a Scott Foster suture, we can easily improve the vertical force to the muscle which is weak. And the best part is this is on an adjustable suture, and so we can easily adjust it at about 5 or 6 hours after the surgery to give a more predictable correction, and as well as improving the abduction, as you can see in the inferior 9 gaze pictures. Another improvement or evolution which has happened recently is the modified Nishida's procedure. in which without disinserting or splitting the vertical recti, we can vectorize the force towards the paretic muscle. The side view is being shown here, and you can see that 8 millimeters away from the insertion of the superior and the inferior rectus, the sutures which are 5-0 ethibond sutures, non-absorbable, are passed, and then we can pass it 8 millimeters away from the insertion of the lateral rectus. Now this is another schematic view of this boy who had esotropia because of 6th nerve palsy, and you can see the improvement in the abduction as well as the primary position deviation. This was a girl who had a bilateral medial rectus aplasia, and in this case we had done the modified Nishida procedure bilaterally, and you can see the significant improvement in her deviations as well as her movements in either side in adduction. So this is a very good procedure, and you can make use of this video if you want to. Coming to the 4th nerve palsy, the inferior oblique weakening procedures like recession and have been said. Anterior positioning has been talked about, but the newer addition is the anteronasal transposition, in which we are reinserting the inferior oblique on the nasal side of the inferior rectus. Now this is a very strongly weakening procedure of the inferior oblique and corrects even up to 4+ inferior oblique overactions, and this is something which is an additional tool which we can make use of. And you can see what we are doing is disinserting the inferior oblique, passing the sutures, and then relaxing the lateral rectus, hooking the inferior rectus. Now after hooking the inferior rectus, you are seeing the view being shifted to the nasal side. The intramuscular septum of the nasal side is being split, and you can see the sclera here. 2 millimeters from the nasal end of the inferior rectus will make a mark, and the inferior oblique is brought on the nasal side and stitched here. Now this, as I said, is a very strong weakening procedure, and it will take care of most of your inferior oblique overactions, be it because of a primary or a superior oblique palsy case. The 3rd nerve palsy, we have used the periosteal anchoring of the globe, and this is also sometimes we have to add the lateral rectus periosteal anchoring because it's a very strong lateral rectus. But now recently another addition has come, is the split lateral rectus transposed medially to improve the forces, and you can see here in the schematic diagram, this is the Dr. Gokijit's modification that we have done, and we have further done as a augmentation procedure that we bring the cross action ends of the superior and the inferior halves of the lateral rectus to the opposite side so that we can get it to work much more efficiently. So this you can see is the small video. And you can see the 6-0 vital sutures are being passed, the muscle ends are being separated, and then they are worked underneath the inferior rectus and the superior rectus. And mind you, when you are working underneath the superior rectus, you have to be also taking care of the superior oblique, and you may have to do a superior oblique posterior tenotomy to make it easier for you. And then we bring it on the medial side, and you'll see that the forces even in a synergistic divergence case can improve the adduction very, very substantially, as you see the synergistic divergence child. Now congenital 3rd nerve palsies can have aberrant regenerations of another kind, in which there may be a downshoot, like in this video you see here. When the child is asked to adduct the eye, it shoots down, and here the problem is the inferior rectus is getting the misinnervation. So what we need to do is disinsert the inferior rectus and put it in place of the medial rectus, as we have done in this case, and you can see the improvement in the marked deviation which was there, the synergistic innervational downshoot, which we have named as
sum up kar do, Pradeep ji.
This is what is done. And on the last slide, I have 1 more minute, Dr. Shukla, and this is the use of the imaging that we can make use of on the MRIs, and we can see the innervations which are going wrong and correct it. So what we nowadays do is a targeted strabismus surgery. We identify the misinnervation and transpose the misdirected muscle to the correct side, and so correct the deviation even in the most complex type of strabismus. We need to be a squintellectual, use your intellect fully and correct the eyes of the patient so that we can restore sight and happiness for all the kids world across and maintain the stereopsis and restore their loss. So this is our mission of SPOSI and each of us, Thank you all for having a patient listening. Thank you.
Thank you very much, Dr. Pradeep ji. This is wonderful. You are one of the pioneers and one of the greatest strabismus surgeons regarding these. Your innovations of the transposition have been wonderful and wonderfully taken. Thank you so much. And now we have Professor Kamlesh. Is he on the line? He will be speaking on intermittent divergent strabismus.
Thank you, SPOSI and the POS for a good show. Good afternoon, everybody. Now, coming to my topic, the management of the intermittent exotropia. By definition, the intermittent exotropia is a type of exodeviations which is intermittently controlled by the mechanism of fusion in order to keep both eyes properly aligned. So most of the times, patients comes with the both eyes properly aligned and
Başka bir bilgisayardan hallettim şimdi.
It is important to realize that the IDS, if treated properly and in time, gives not merely cosmetic but also full functional cure. Now, coming to the its clinical characteristics, which is very important to know, that it is a progressive in nature and involving first the distance and the later the near fixation, but not always. Exposure to the bright light may cause reflex closure of the one eye, which is probably due to the diplopia resulting from a destruction of the fusional ability. Mind it, till this time, the development of the separation has not taken place. But in children less than 10 years of age, may develop sensorial adaptation. Separation in the tropic phase can be commonly demonstrated and takes the form of temporal hemiretinal separation. The amblyopia may be rare if by the way present. There is a high AC by OC is usually present. The trophic phase may be aggravated by many factors like the daydreaming, fatigue, illness, fatigability, visual distraction induced by the thinking and speaking at the distance field. And coming to it can be associated with AB patterns, maybe without oblique overactions, or maybe with the oblique overaction, inferior oblique, other superior oblique, both in the form of weak. So with the inferior oblique, with the superior oblique overactions. Now coming to the classification, which is very, very important, and this has been laid down by the two great people, the Burian and the Kussner. I'm taking about Burian's classification. This is basically four types he has described. The one is the basic type exodeviations, in which the deviation for both distance and near is almost equal within the present diopter. The divergent axis type, which is the true and the simulated again. In the true, the distance deviation is always more than the near, by at least by the 10th present diopter, even with the occlusion. And there is the simulated, in which initially there is a difference of 10th present diopter between the distance and the near. But by breaking the fusion or the suspending the accommodation with the plus 3D lenses, it comes almost nearer, meaning thereby less than 10 present diopter. And another is the convergence discrepancy, in which there is the deviation for the near is always greater than the distance by 10 present diopter. This is the Kussner classification. In fact, one thing I would like to know that that in the true divergence, the Kussner said that in 60% of the cases, there is a high AC by ratio, and in the 40% cases, there is the normal AC by ratio. He emphasized the fact that in the high by ratio cases, there is a high chances of post-operative overcorrection. So one has to remember accordingly plan to not overcorrect. So this is Kussner. Because of the time limit, I am not taking it. The age of the onset is usually 0 to 10 years, and the peak incidence is the 5.5 years. Now, this is the case of infantile exotropia, which need to differentiate from the intermittent exotropia by way of constant large exotropia since birth. This is the one test which is a very, very important, single most important things in the management of the ideas. What does it do? That we have to utilize it to determine the full static deviation. Whatever we see, that was a dynamic deviation it used to be. So we have to determine the static deviation for both the distance and the near. I advise personally for everybody that you repeat it many times till you get the two matched findings or the similar findings. And it also determines the distance near disparity I mean, differentiate between the two and simulated evidence. And last but not the least is know your post-operative success. Amidst all these dilemmas, so many dilemmas is here, surgery is mainstay for the intermittent heterotropia, besides the non-surgical treatment, which I must say that as a fundamentally, in any case of the squint before surgery, try to maximize vision by treating amblyopia or anisometropia. The minus lenses may act as a temporary measures, stimulating accommodative convergence to control the exudation. Base in prism spectacles is again may be used to compensate for the exudations. These may, however, reduce the stimulation of the fusional convergence. Regarding the orthoptic exercises or the orthoptic training, etc., again it is a controversial. Some say that it is not a substitute for the surgery. Again, the lady treatment say that there is no effect between the pre-surgical and this orthoptic. But anyway, there is a different role of orthoptics in the form of anti-suppression therapy, diplopia awareness, and the fusional convergence training. Now, what is the indication of surgery? That is actually when you have the sign of progression or the signs of deterioration, and that is the progression of trophic phase, meaning thereby from the progressing from the infrequent duration to of the smaller magnitude to the frequent duration of the larger greater magnitude, and secondly, exotropia occurs more than the 50 hours of the waking hours, especially in the children. Secondly, convergence insufficiency, increase in the size of basic deviation, and the development of the suppression. And the previously patient said, I was having diplopia, now he is agent. Timing of surgery in the IDS is again a controversial sort of thing, but now almost we have realized that delay surgery in the visually immature infants to avoid overcorrections for the jump palsy also mentioned. And not only that, for the proper preoperative assessment and to avoid the amblyopia and loss of hysteresis due to the desired initial consecutive esotropia. At the same time, Knapp and Dunlop mentioned that surgery can be done even before the 4 years of age when you see the signs of deterioration in order to maintain the binocularity to avoid the intraocular sensory changes. The goal of surgery, most of us now agreed upon that a small surgical overcorrection of 10 to 20 prism diopter, what I do the 8 to 10 prism diopter, but most of the people are still not agreed. They do undercorrection or the AMI to the orthotropic position. Now, what is the surgical consideration? That again based upon the clinical types. In the basic type, you usually do the R&R procedure. But if the this deviation is very less, then you can attempt the bilateralization also of the lateral rectus. But in divergent cases, the bilateralization is no doubt the choice of surgery. In a convergence insufficiency type, there is a bilateral MRization whenever required. Now, if it is associated with the AB pattern, there are some important surgical considerations which have to remember. That select the surgery to reduce the horizontal deviation in the primary position. Horizontal muscle transfusions will work well if no oblique dysfunction. But remember that it is not a substitute for it. And dear friends, always remember that primary and the reading positions are the functionally most important position of cases. So unless until it is required, it's not required in almost all the cases to be filled. Suppose in this slide I have shown that in the Leo version you have the 40 prism diopter, straight 30, and on the Dexter version 20 prism diopter of deviations. And if the difference between the list and the test is not less than 20% and more than 50%, then this condition is known as lateral incompetence. So what will you do in this condition, or why will you do? Just to get the binocular gain well and as well as for the cosmesis. So there may be the two options. Either you have to have weaken the lateral rectus or do the more recession of the lateral side than the right side lateral rectus. And secondly, you can attempt you have to weaken the medial rectus of the same side by way of R&R. So you can see, as I said, the excellent cosmesis change in the personality. You see the personality on the left and the right side. Here again, now this lady is a pilot. Here you can see not only the cosmesis, you can get the good visual function gain irrespective of the age, the associated image patterns, maybe obliques, etc. So always this is gainful.
Now this is the last slide I am showing, the post-operative care and the follow-up, which is very, very important, dear friends. And as you know, as I said, the small conjunctival surgery is desired 8 to 10% doctor. And if that is there, most of the patients may complain of diplopia. But remember that it resolves within the 2 weeks time, so no worry. But if esotropia persists for more than 2 weeks, what will you do? You can use base out prisms, or if that is also persistent after 8 weeks, then resurgery, bilateral lateral advancement, as I do. If residual esotropia for near only, you can prescribe the bifocals, myotics, or the base out prisms, or sometimes you need to do the bilateralization with the fodder. Thank you very much. Can I show you one video? Yes, Dr. Shukla.
Yes, sir.
This is a small video of 30 seconds.
No, sir.
I thought Professor Sharma will show it, but he has not. But then this is a good chance I am showing it. So this is the transposition procedure of the horizontal muscles to tackle the V pattern without any inferior oblique overactions. I'm using the 6-0 axial sutures to physical, just pinpoint from the middle, and in the down position, half tendon with a half tendon. Pass this needle and try to caution that it should visualize from the top so that it should not perforate the sclera and go inside, otherwise causes so many complications. And then you have to tie. This is a very simple procedure, and it can correct around 15 to 20 prism diopter of the isoseph. And yeah, that's it. So it can correct. There is another procedure slant also that correct 10 to 12 prism diopter, and this up-down displacement can up to 5 to 8 millimeter can correct.
These are simple surgeries. I think everybody knows about it.
Yeah.
Thank you, Kabirji. So nice.
Yeah. Thank you.
Yeah.
Thank you, sir. Thank you very much.
Now we have Dr. Rohit Saxena with us, another very promising and budding strabismologist from AIMS, and he would be speaking on over and under corrections in horizontal strabismus.
Thank you. Thank you, Dr. Shukla. I'm audible?
Yes, sure.
Thank you. And I have started my screen share.
Yes.
So I'll be talking about the management of over and under corrections, and I thank Dr. Shukla, Secretary SPOSI, and the entire SPOSI organization to give me this opportunity. So when we are looking at post-op misalignment, we have overcorrections which could be planned or unplanned, undercorrections which again could be planned or unplanned, and we could sometimes have new developments or missed findings like missing an oblique overaction because of a large horizontal angle that comes up once you see the patient with a lesser horizontal deviation, or the presence of DVD, which is frequently seen in infantile esotropias. So the first step is to prevent these complications of over-under corrections, which can leave the patient rather dissatisfied. So the key thing is proper refraction. So cannot forget proper refractions. That is one of the major causes for post-op surprises. And of course, do not operate on pseudostrabismus or what the patient feels is deviation, but it is not truly there. This was a patient of post-op infantile ESO who came to us. You can see on the primary gaze, the child looks pretty well aligned. But the moment the child looks down, you can see that there is an A pattern, and probably the superior obliques were missed at the time of primary evaluation and were not touched. So the importance of doing a complete 9-gaze assessment. So not only are you seeing the horizontal deviations in the horizontal 3 gazes, but in up gaze, down gaze, also in the tertiary positions of gaze, where you can see an inferior oblique overaction in this case. So do not miss the obliques when you are planning for horizontal surgery. Another post-op case, you can see the child looks pretty well aligned, but frequently the hypertropia remanifests, and a missed DVD was the diagnosis. So again, whenever you are having a patient with deviation, always look for associated problems like obliques, DVDs, Sometimes DVDs may manifest a little later, particularly in infantile esotropia. So it's important to assess preoperatively as well as in a follow-up period. The other important thing to look for, to remember, is that in recent acquired strabismus, it's important to wait for stabilization of the deviation. So unfortunately, if you are very aggressive and you operate early and the muscles recur, come back, function comes back, you will have a consecutive deviation. So always wait for stabilization of the angle before you plan surgery. So sometimes we have a horizontal deviation which may be acceptable as a long-term result. So you have small over or under corrections which may be acceptable, particularly if the patient is not suffering from diplopia. You may plan actually post-op misalignment, like in an adult when you're operating intermittent divergent squint, you may look for a slight overcorrection of about 8 to 10 prisms of esotropia, which we know would drift out over time. Of course, long term, sometimes this patient do not drift out, or you have had a larger esotropia which may require intervention. Then in sensory exotropias or sensory esotropias, I prefer to leave the eye slightly esotropic in the post-op period, because there is a long-term tendency of the eye to drift out, and therefore you mildly overcorrect a sensory exotropia or mildly undercorrect a sensory esotropia. However, despite all our best efforts, resurgeries would be required in up to 10% of cases, and of course it is more in paralytic squints, in restrictive squints, in large angles, where if you operate one eye, if you prefer to operate one eye, you do a large R&R procedure, you are expecting that there would be residual in the other eye, which you may tackle in the other eye. The advantage of dividing the surgery between the two eyes is that you will not get significant palpable fissure changes between the two eyes. You can follow standard nomograms, and if by chance there are oblique overactions in both the eyes, you would anyway have to operate both the eyes, so it would help you to get the exact correction after the second surgery. But of course, it's important to discuss this with the patient preoperatively. The important things when you have a patient with unsatisfied horizontal or vertical deviation post-operatively is important to assess what was the pre-op deviation, what was the planned surgery. So try to access the preoperative notes, especially if you have not been the operating surgeon. You need to assess what was the planned deviation and how much correction was planned. So was it that the horizontal deviation was planned to have a little under or over correction, or this is a post-op surprise? How was the early post-op alignment, and is the deviation progressing over time, or was the result poor at the very first post-op period only? And of course, if possible, look for pre-post-op photographs if available. When you are assessing the patient, look for the deviation in primary gaze. Look for incomitance, because that is a key cause for horizontal deviations and a key intervention you will have to correct. Look for versions and ductions. Is there any limitation of movement? Are there any retractions that have now been visible? So you need to do a force duction test, and if required, an active force generation test to differentiate between a restrictive residual squint or a consecutive squint to an underaction because of either a muscle slip or an excessive recession that you have operated on. Now, sometimes when you don't have records, conjunctival scars can be looked at to help you to identify what actually was done, which muscle was recessed, which was resect. It may not be helpful for vertical or cyclovertical muscles, but it's important in horizontal, especially a canalicular distortion that may tell us. And of course, you can locate the muscles by using the UBM or the ultrasound, which can help you to identify whether this muscle was operated upon or not. Now, to prevent unacceptable outcomes, you need to do careful workup, a careful choice of surgery, be consistent in the surgery that you're going to do, because surgical variations itself can bring about unpleasant outcomes. And of course, use your experience to adjust for differences in presentation. So if there is some amount of restriction or a contracture of a muscle, you know that outcomes will change and you have to adjust accordingly. So if you have an unacceptable outcome, you need to wait for full effect of surgery, especially when you're looking at a residual deviation. So sometimes the maximum effect of surgery may take time. So you wait for the full effect. Up to 6 weeks to 12 weeks can be comfortably waited to see the full impact. If you have a consecutive, you may need to intervene earlier, particularly as sometimes the patient may have diplopia or the patient is extremely sensitive about the deviation that is now in the opposite direction. A consecutive ESO, you can re-refract with age-appropriate cycloplegia, can do alternate patching to prevent amblyopia or diplopia, and if it's a small angle, look for prism neutralization. Sometimes a consecutive ESO may actually drift out, especially if it was a large angle exo to start with, and you may get alignment over the 6 to 8 weeks. A consecutive exo, you can undercorrect the hyperopia. You can give fusional exercises, especially if the patient has become an intermittent deviator. If there is no incompetence, could others please mute themselves? There is some background noise. So if there is no incompetence, possibly operate the other eye with usual nomograms. It always helps to operate the other eye because your standard nomograms are. Somebody is talking in the background. Please could the administrator please mute the others? So if it's possible, operate the other eye because usual nomograms will be active. If it's an operated muscle, if over time the muscle undergoes changes and therefore your outcomes may be different. If you reoperate the same muscle, remember the safe limits. Re-recession or re-resection, you may actually cross the safe limits and itself create underactions of the muscle or a retraction. If there is limitation of movement, you will have to revisit the eye. If there is a restriction, you need to relieve the restriction because the tight muscle will always remain there and cause limitation of movement. If there is an underaction, you will have to advance the same muscle because the force in the muscle is now less. You have to see for whether it was over-recessed or if it's a slipped muscle. So again, essentially you have to wait for 6 to 8 weeks to see for the maximum effect of whatever change that has happened to allow for proper healing and resolution of edema before you could possibly intervene. You need to intervene much earlier if there is limitation of rotation, decreased saccades, or over or under corrections. A slipped muscle, it's important because you need to identify if there is an adduction deficit or widening of palpable fissures. And of course, in this case, we have a possible missed MR because of a consecutive exo. Residual exos, most common. If an RNR has been done, rotations are full, plan the other eye. If bilateral lateral rectus recessions have been done, you can further recess. Remember, additional recessions would yield larger corrections. You could go ahead with medial rectus resections also, although the effect of surgery is much less. Residual ESOs, you have the option of either doing a lateral rectus resection or you may recess the MRs further, but again remember the safe limits. If there is incompetence, you must correct. If there is a slipped muscle you suspect, you need to go back, re-explore and put it back again. Consecutive ESOs in a younger child are very, very important to look for and avoid, and if necessary.
Sum up, Rohit.
Yes, sir, closing in the last slide. A consecutive ESO with abduction deficit, look for lateral rectus slippage, and of course, if there is not there, you can do an MR recession. LR slippage versus tight muscle is something that you must always look for and go back. And of course, consecutive exos, you can wait for some time, but otherwise you may go back and do an LR recession in these patients. If no limitation of movement, you can do the other eye or reverse the previous surgery if an RNR procedure is done.
Okay,
so despite meticulous pre-op evaluation, you would be having pre-op post-op.
Thank you, Rohit. Thank you very much. Thank you very much. Now we have 5 minutes only for questions. Dr. Karimji, do you have any questions for the panelists and the speakers? Dr. Fatima, Dr. Berson, please be on the line. Karimji, do we have any questions?
I have some questions.
First, let the audience ask, please. Just a minute, Dr. Berson.
Okay.
Let the audience ask the questions first.
Of course.
Any question, Karamjeet, from the audience? I mean the viewers.
There is no question.
No question.
This is session, but it is from the previous session.
नहीं, previous session का तो गया, वो बात खत्म हो गई. We don't have time. We are already 15 minutes late because वो बंद हो जाएगा. Any question? Yes, Bersin, you wanted to ask something now?
Okay. I ask a question, similar question to Dr. Fatma and Kamlesh. I asked to Dr. Fatma, how often you met anti-elevation syndrome in your practice for inferior oblique anterization? And for Dr. Kamlish, how often you met the operation for intermittent exotropia? Because we talk about the literature, we don't ever talk about our practice, and I need to know about them. And last one, Rohit, hi Rohit, and I noticed that Rohit said that in exotropia, if there is the sensorial exotropia, to perform a little overcorrection, but we always perform less correction both in ISO and exo, because that
Dr. Person, you please ask one. No, you please ask one by one. First question, to whom do you want to ask? Because you know that there is a confusion.
Dr. Fatma.
Dr. Fatma, okay. Dr. Fatma, what do you ask? Please repeat again. We have.
Okay, let me shortly answer. I have one patient with anti-elevation syndrome who has been followed for 8 years.
Can you speak loudly, please?
I have 2 patients who have been referred from another clinic with anti-elevation syndrome. I think that sometimes it's hard to diagnose these patients because of the differential diagnosis. You know, the inferior oblique overaction in the other eye, it may mask inferior oblique overaction in the other eye. It may mimic the same picture. We should be careful for the palpebral fissure narrowing in the eye with the anti-elevation syndrome, and the lower eyelid curvature may be decreased, and the bulging of the lower eyelid are important signs in addition to the axial torsion, which is present in the eye with the anti-elevation syndrome for diagnosis. I have so far about 3 patients in about 15 years, but 2 from other clinics, but it's not rare.
Okay, thank you.
You're welcome.
Okay, the next question, Dr. Birsen.
Dr. Kamlish, how often operate intermittent exotropia in his own clinical experience?
No, his topic is on intermittent exotropia, not esotropia.
I said exotropia. Intermittent exotropia. Okay.
I'm sorry, what is the question?
How often you met the patients to go operation in intermittent exotropia? Because in very few cases can control their deviation in our country, and most of them goes to the operation in 1 or 2 years, and I need to learn about your experiences.
1 to 2 years, as I said that it may be whenever, generally we don't operate it, but if there is a signs of progressions, and in which we can see that can deteriorate the vernacular status and all that, then we can do by the half-strong method and to determine the whatever we can, the static deviations by repeating many times, and we come to know that this much, then we can go ahead.
Kamlesh, her question is that a lot of people can control the deviation. So when do you go for surgery? Just a question.
When we fail, that's what I am saying now. If there is a sign of deterioration or the sign of decompensation is there, besides that the stereoacuity at distance is at stake, not normal, then we can go for the surgery with the signs of deterioration, measure the static deviation and do the surgery.
Okay, thank you.
There is a question from the audience.
Oh, yes, please take the question.
To Dr. Kamlesh, do you perform different recession or resection for a V phenomena?
For?
Yes, sir. V phenomena.
V phenomena, as I said, that transposition procedure, if there is no oblique involvement, and if there is a oblique involvement, we can do the the oblique muscle surgery, whether the recession and weakening or the strengthening process, whatever is required.
Sir, another question is.
I'll just make one observation here, that most of the general ophthalmologists take V phenomenon as a horizontal dysfunction, but most commonly it turns out to be an oblique dysfunction when the patient comes to us. So it's very, I mean, it is there that we have a V phenomenon in the absence of oblique dysfunction, but the proportion is much lesser as compared to what we find with the oblique dysfunction.
Yeah,
that's true. Another question is to Dr. Fatima. Do you perform, yes. Dr. Fatima, do you perform denervation and expiration of inferior oblique?
Personally, I don't. I usually do inferior oblique luxation if I reverse the anteriorization surgery, and I usually don't need extirpation surgery in my patients. Probably I don't see that much overaction.
I believe nobody is doing.
Another question is, do you give Botox for consecutive isotropias?
Pardon me?
Do you give Botox injection for consecutive isotropia?
Botox, Dr. Fatima.
Of course. I usually try it. In consecutive cases, I always try Botox injection.
Okay.
It's my usual procedure, and it's the easiest way. But I usually wait for some 4 weeks or 6 weeks, and then if the patient is in problem with the diplopia and can't manage, I usually try Botox initially.
Sir, last question from the audience to Dr. Rohit. Dr. Rohit, sir, do you perform tenotomy to tight muscles with conjunctive iso and exo?
Free tenotomy is no, I would never. I mean, always recess. Graded recessions or graded weakening procedures. And just to answer Dr. Goki when she had asked about the
overcorrection
post-operative, yeah. So I always leave the eye for sensory exos particularly, I leave the eye slightly overcorrected, have a slight esotropia, because there is that repeat tendency of the eye to go out with time. So they would come back with a repeat sensory exo. That's why I would prefer to leave it very slightly overcorrected so that the tendency of drift does not. But that's in my experience. That's why I overcorrect.
Okay, we will have to stop now. We are already over time. We have already crossed.
One question to Dr. Pradeep Sharma, sir. Sir, we have read in the books that quite a lot of intermittent divergent squints improve over a period of time, and they do not require surgery. But in the practice, we usually find most of them actually worsening. In last 10 years, I have just 1 or 2 patients who have improved with glasses or maybe with follow-up. So what's your experience actually vis-a-vis what is written in the books practically in Indian scenario?
Our experience is that they are not going to improve on their own.
Yes.
Even Von Nuden's study had shown that 75% deteriorate over a period of time. Okay. So in the British, I think literature you find, or people are little more wary of doing operations in intermittent divergent squints, and so they say no, defer the surgery. But we have to see that if it's causing loss of binocular vision, maybe in the form of distant striopsis or near striopsis, we need to intervene. You can give exercises as an option in the period that you're waiting, but you may have to do surgeries in most of the cases. Maybe 75 to 80% of the cases will require surgery.
See, the problem with the convergence exercises is, Dr. Pradeep, if you agree that we are not sure about the compliance of the patient, how much they're doing, and whether they're doing it correctly or not. And the second thing is how much exotropia can be improved with exercises. There is a mark. Can you tell about that?
Functional ability of a person. There are people I have seen who have 55, 45 prisms of exophoria. They continue to have it if they have a very good convergence. So it doesn't go by how much deviation, but it goes by how much is the fusional ability of an individual. So if you have people who are fusing well, I have seen some people who can, but these are few. Maybe only about 25% or 20% of the cases which may have good fusional results, and you can strengthen.
Okay.
I agree. Can I add one thing?
Yes.
I think regarding the Ankur question, that if the fusional ability of the patient is good one by judging the studio acuity at distance, some people are using even the minus lenses or the prism spectacles for sometimes restoring the good vision at 6x6 and all that, and in the due course of time that maybe revert back to the
More blindness mainly with high AC biration.
Yeah, that's true. That's true, but this is the one. That's fine.
Okay, we close this session now. We have already crossed a lot of time. Thank you very much, all the speakers and panelists. Now we go to the last session, which is pure pediatric ophthalmology. And we have on the panel Dr. Vinita Singh, Dr. Sumita Agarkar, Dr. Kalpan Narendran, and Dr. Milind Khilidar. And we start this session now. Dr. Karimjit, you please take the monitoring of the time. First is paradigms of corneal pediatric transplantation, Dr. Namrata Sharma, Dr. Jethani, Dr. Baronaik is not there. He is already telephoned, will not be there. Rajesh Sinha, Vishali Gupta, and Santosh Honavar. Please to go, Dr. Karimjit, because I have some work.
Thank you, sir. So over to Dr. Namrata Sharma for her first talk. Dr. Namrata, ma'am.
Is it showing and am I audible?
Yes, very, very good.
Okay, thank you so much for inviting me. I would like to congratulate SPOSI. I think this is the first midterm program done by any society on a webinar. And I would like to congratulate all the office bearers and would like to thank them for having me here, particularly the President, Dr. Khokar, Secretary, Dr. Yogesh Shukla, sir, and Dr. Karamjit Singh, who's the organizing secretary for this. So it's a honor and a pleasure to be presenting here in this SPOSI meeting on a topic which is related to pediatric ophthalmology, corneal transplantation in children. And there are no financial or proprietary disclosures. If you look at pediatric corneal transplants, they constitute 1.9% of total corneal transplants, and by far 28% surgeries are lamellar, and surgeries in general can be penetrating or could be lamellar. This is the review article that we did in Current Opinions on Targeted Corneal Transplantation, and there are differences in adult vis-a-vis pediatric keratoplasty in terms of preoperative, intraoperative, and postoperative care as well as outcomes. So this is pretty much from a review article that we have done just last month on lamellar keratoplasty in children, and we are no longer now doing overkill of doing a complete replacement of the layers into full thickness or partial thickness corneal transplantation procedures. But what we are doing now is a competent surgery of cornea wherein only the diseased layer is replaced by a healthy one. So coming to the pediatric keratoplasty, which is full thickness corneal transplantation, it can be done for congenital opacities, acquired traumatic corneal opacities, or acquired non-traumatic corneal opacities. And this is the update on pediatric keratoplasty, which is a little old, but this our newer review, 13-year review in 2019, looked at the 2,000 plus cases and said that PKP was by far much more common as compared to the corneal transplants. And in totality, ectasias and thinning disorders were the most common cause for which pediatric keratoplasty was done. But if you look at from the age point of view, in the younger age group, it is congenital opacities as is expected, which are the most common indication. And as the age increases, the ectasias they become cases wherein more and more keratoplasty has been done. Now we look at our data and we compare it with the data which is there vis-a-vis the West. The congenital corneal opacities are more commonly the indication for corneal transplantation in children as far as the Western world is concerned. But for us, it is the acquired non-traumatic cases or healed keratitis or infections which are the most common reasons why we did corneal transplantation. And this looked at 168 eyes wherein infectious keratitis, either healed or the active, were the most common reasons why corneal transplantation were done in children, and the overall graft survival rate was 77%. Now, this is again to look at the same data where we thought that our congenital cases were far fewer as compared to cases which are acquired and non-traumatic. Now, this is just to show some of the indications: healed keratitis. These are congenital corneal opacities, iridocorneal dysgenesis, congenital glaucoma, for which these are done, post-traumatic corneal scars, and then repeat grafts, which is again an important indication because children generally remain or survive for a prolonged period of time, and you may have to repeat grafts and then healed eye drops in cases of keratoconus. So the factors which determine the success or failure can be preoperative, intraoperative, or postoperative. It is important to do examination under anesthesia for children. You may need a portable slit lamp. Visual potential needs to be assessed. Perkins applanation tonometry has to be done. You may require UBM or ASOCT or even intraop OCT if it is available at your center. Systemic comorbidities may require GA clearance, and examination of the siblings and parents may be required. And you have to deal not only with the children but also emotional parents and the entire family. There is positive vitreous pressure when you do a penetrating keratoplasty. So preoperatively, intravenous mannitol should be given, ocular massage and hyperventilation should be given, GA should be given with the muscle relaxant. They tend to have small eyeballs, so the surgical steps will become difficult. Appropriate sized speculum may be used, alternatively lit sutures may be used. Lateral canthotomy also helps in these cases. The scleral rigidity is generally low and the elasticity of cornea is high, so trepanation of the donor graft should be done before the trepanation of the host. There are chances of damage to iris lens diaphragm, and there could be difficult surgical manipulation and suturing. Now, in cases of keratoconus, we either use same size or 0.25 millimeter oversized graft. We have described the use of oversized graft by 0.75 to 1 millimeter in children to avoid compression of the angle and allow adequate AC depth. Initial debulking in cases of adherent iris may be done and avoid unnecessary pressure over the globe. Now, this is of course a little older child with healed eye drops, but just to show full thickness penetrating keratoplasty, wherein the Hesburg-Barron suction trephine is being used. The cornea is excised, and this is then replaced with a full thickness donor cornea with 10-0 monofilament nylon sutures, which are placed in situ. What now we do is for every child that comes in, we are doing a UBM. So this is a UBM to show the same. So if the corneal opacity is dense, you can't make out what is there underneath. For instance, in this case, the same thing is also seen under the intraop OCT microscope, and you can see here the thickness of the cornea. Cornea is so thickened. In all cases which undergo penetrating keratoplasty, it is important to put a Flerenga ring, which is put with the help of the vicryl sutures, because the scleral rigidity is low and there will be a collapse of the anterior segment as you do the surgery. And then subsequently, this is a case of aniridia, so there is no iris also, and the lens is actually staring at you, and that is why UBM and intraop OCT is very useful in these cases. Now, again, when there are iridocorneal adhesions such as this, and there's a membrane which is present, you can't make out. But if you look at the UBM, and if you look at the intraop OCT, then you can make out where the iris is, where the retrocorneal membrane is, and then one can do a dissection looking at these pictures. And as soon as the excision of the cornea is done, the iris pops out from there. So again, there could be adhesions which may be there at the back, which you can see. So very slow debulking of the cornea is done so that maximum amount of iris is preserved, and full thickness donor cornea can then be placed over the recipient bed. Now, sometimes there can be large central adhesions. So look at this on the UBM. The cornea is so much thickened, and you really can't make out what is the picture unless you look at the intraop OCT microscope and look at the adhesions between the iris and the back of the cornea. So you know that you have to do a very careful trepanation, or maybe do it with the hand itself just by giving a mark on the cornea, because you don't know where the iris is and you don't want to trepanate the iris when you are trepanating the cornea. So intraop OCT microscope helps in these cases. There can be complications. The biggest complication of a penetrating keratoplasty, more so in children, is allograft rejection, 40 to 50%. Apart from this, there can be secondary glaucoma and also graft infection. And coming to the lamellar procedures, which we are now doing more commonly in children. This is the Survey of Ophthalmology article, which was just published. So we can do automated lamellar therapeutic keratoplasty, in which the microkeratome is used to fashion the donor cornea. 500 microns cornea is there, so it is split into 350 and 150, and the anterior 350 is taken, and this is a keratoconic cornea. which is again cut with the help of the microkeratome, and a partial thickness cornea, which was initially fashioned, is then taken and is sutured with 10-0 monofilament nylon sutures. Now, if you look at the interface, it is there in these cases because it's a stroma to stroma apposition, but this interface is quite clear. And there are revisions which may be required, but overall the visual outcomes are good, especially when they're combined with adequate amblyopic therapy. Now, coming to deeper lesions, the gold standard is big bubble deep anterior lamellar keratoplasty when the endothelium is good and the anterior part of the cornea is involved. These are the indication for DALC. Notably in this are dermoid and mucopolysaccharidosis, which are there for children, and also stem cell deficiency. So this is just to show a big bubble DALC video. So trepanation is again done, and the air bubble is instilled in the supra-Descemet's membrane compartment. Once this is done, one can actually see that the Descemet's membrane has gone at the back, and as you give a nick in the overlying stromal layers, the Descemet's membrane marches just like a live show towards the overlying stromal layers, so you know that you are extraocular and you've not penetrated the cornea at all, and the whole procedure is extraocular. This then is reinforced with a viscoelastic cushion, which moves behind just like a kangaroo's couch, the Descemet's membrane. And then on this viscoelastic cushion, one can do the excision of the stromal layers. This is a bare Descemet's membrane which is looking at you, and you are still extraocular. And 10-0 monofilament nylon sutures are then placed. So there are chances of perforation, which one has to be careful about, and there is chance that the Descemet's membrane may go in between Dua's layer and the Descemet's membrane, what we called as IDMA. And again, there are ways and methods to manage that. Now, this case I would like to show you Hurler syndrome, for wherein the DALC was done, and now it's follow-up almost 11 years with the best corrected visual acuity of 6.9, and we never entered the eye. The procedure is still extraocular and the patient sees well. The outcomes would depend on a lot more things like indication for surgery, age of the child, the graft clarity does remain good, and there is hardly any endothelial loss, cell loss, because you're not entering the anterior chamber at all. And astigmatism is also less because it is a procedure which is lamellar and not full thickness. For cases such as this, a one-eyed child lost the other eye because of phthisis bulbi, lamellar keratoplasty done, visual acuity of 6.9, has now even passed his engineering exam first year. This was way back when he came like this and he was operated. So sometimes it is very gratifying. And this is a lamellar procedure again. So there are no problems of full thickness keratoplasty at all. Now, for posterior stroma, there could be various problems, more notably CHED and ophthalmos in children, and we like to do a DSEC for these cases. So this is a case of CHED, and air bubble is being instilled. Diseased Descemet's membrane is being removed here, and here you have to be a little careful because the child is phakic, not pseudo-phakic, unlike an adult when you are doing a DSEC. So one has to be careful. You don't want to damage the lens at all. And this is the Descemet's membrane which has come out, which has been stained, which is diseased. And this is lenticule which has stroma, little bit of stroma, and endothelium which is quite normal. This is then instilled intracamerally, the graft. And then once you put the air bubble, you start seeing the graft. Before that, you don't see because everything is so hazy. And this is the introp, and this is how it, over a period of time, it keeps clearing and it clears up this much. So you don't have to do a penetrating keratoplasty, and just by doing a lamellar procedure, one has done this. Again, ophthalmos are cases wherein, you know, penetrating keratoplasty would be a disaster because the corneas are so big, the corneas are so thin. So if you do a lamellar procedure such as this and just put a graft at the back there, then cornea over a period of time would clear up. And even if you have to repeat it again and again, like in this case, you've not disturbed the anterior part of the cornea, and that is a big advantage of doing a posterior lamellar surgery. So there are again graft detachment can occur in children. You have to do examination under anesthesia frequently, and these problems can be addressed. Of course, DMEC can also be done, and just like DSEC, except that you have a pure Descemet membrane roll there. and the outcomes for all the corneal transplantation procedure depend a lot on how you address the amblyopia post-operatively. So to conclude, children do pose a unique set of challenges when undergoing corneal transplantation. Successful transplants can provide vision to an otherwise non-seeing eye. To maximize success in cases of children, it is important to follow them up very frequently with robust post-op care protocols, and failure to come to follow-up visits is associated with lower survival rates. So that is something which has to be highlighted to the parents of the patients. Thank you very much for your kind attention, and I would be very happy to take any questions if there are. Thank you so much.
Dr. Sharma, I will ask you one question. Compared to a corneal procedure, what do you think about optical iridectomy?
I think that's a great procedure, and I think there are some cases where you just do optical iridectomy and the child gets good visual field and also gets good visual acuity. So again, like I say always, you should defer a corneal transplantation for as long as possible in case of children, because the story starts from when you do a corneal transplant. It doesn't end there. So it's like a lifelong follow-up, lifelong medications. So if with optical iridectomy, if a patient say gets about 618 or for that matter even gets about 624, I would be happy and not do a corneal transplant for that patient. So corneal transplant in children should be the last resort.
Thank you so much. Again, for glaucoma, sometimes corneal opacity is completely clear as the pressure gets controlled, but sometimes there are these scars which are vertical and which are right in the visual axis. What is your procedure of choice in those children?
The scars are there which are partially in the corneal axis. There are other modalities also which are there. Like we could probably do a contact lens trial, and like I said, that if there are corneal scars where contact lens trial is feasible or optical is possible, then it's always best to resort to non-keratoplasty options for managing corneal opacification. Secondary glaucoma is a problem, and in pediatric grafts, secondary glaucoma is present as much as in 1/3 of the cases. So that has to be done with a glaucoma specialist.
Thank you.
Thank you, ma'am. Thank you very much.
Thank you, Dr. Karan.
The question answer will be taken.
Any audience question, Dr. Karamji, on this topic?
Those will be taken at the end of the session.
Okay, thank you.
So our next topic is pharmacological management of myopia by Dr. J. Jethani. Pharmacological management. Are you ready with your presentation, sir? Dr. Jitendra?
Dr. Jitendra? Okay, yeah, he's coming.
Yeah. Am I audible?
Yes, sir.
Yeah, the screen is visible, right?
Yes, sir. Screen is visible, sir. You can start.
Thank you. So at the outset, I would like to thank Dr. Shukla, sir, and SPOSI for giving me the opportunity to share my work on low concentration atropine to control the progression of axial myopia in children. To begin with, I think this it's not moving. Yeah, so we don't have any financial disclosures to make, and I think it has been a long journey since 2012, and now, I mean, the basic consensus is, and we are pretty sure that this particular drop works. And in the beginning, we had some resistance, or maybe some thoughts that probably it was not working, or it was not working at that particular concentration, like 0.01%. We all know since years altogether that atropine is a very important way of stopping the progression of myopia. And there have been multiple theories regarding the same. One of the most plausible and most acceptable theory at this point of time is that atropine affects the dopamine neurotransmitter release from the cellular stores, and which may influence the retinal signals, which would control the growth of eye and Dr. Jyoti Matalia from NN had presented her findings at AIOC conference and at a WSPOS meeting at Hyderabad, where they could see atropine eye drops affecting the concentration of dopamine in tears. They measured the amount of catecholamines, especially dopamine in tears. The advantages of low concentration dopamine over low concentration atropine eye drops over a 1% is obviously that there is minimal to no effect on accommodation, and since the concentration is low, the chances of side effects are minimal, and the retardation of progression, of course, doesn't seem to be exactly dose dependent and is comparable with atropine 1%. And now it is easily available, especially the MyAtro and other products are available. Our experience, we started very early, and at that point of time, we were not having the commercially available low concentration atropine. And all our patients, I know most of us have a huge number of patients who have progression of myopia, and they keep coming on follow-ups. And so we started way back in 2013. This is some of our experience which I am sharing. And we had around 358 children. The mean age was 6.4 years. So out of all this, there were only 12 children who did not respond at all to atropine 0.01%, and this was the baseline axial length and spherical equivalent, and this is the mean growth in every year. And so we also did a comparison with the placebo, and we did an RCT. Obviously, the number was very small in placebo. Only 60 children were taken in two groups, and this particular graph shows that there's a huge difference between the control group and the atropine using group. But as you can see, the growth in terms of head-to-head comparison between a placebo and a atropine eye drop user. So we all, I think we can understand from this particular series that low concentration atropine does work, and it is a very important drops in our armamentarium to fight against the progression of myopia. Moving further from this, we also tried it. I think there is some buzz about what happens in the myopic shift in children. So we did try it out in children post-op pediatric cataract patients. We all know that Dr. Vaishali has covered it very nicely in her presentation and the subsequent presentations. We know that myopic shift is shown in pediatric cataract patients, and some of this shift keeps on happening even after 2 years or continues up to 5 or 6 years. So we did use low concentration atropine in some of these children. So as you can see from this particular table, so we started using these drops only when they were above 4 years of age, and it did help in reducing the progression of myopia. We also there were some concerns whether it affects the pattern ERG, and we could do a pattern ERG pre and post, and the pattern ERG which is shown on the left side of the slide is actually my own pattern ERG. I had put atropine in right eye, atropine 0.01%, just to find out, and we did this in 3 patients, and we could show that there was not much of a significant change in pattern ERG after using the atropine 0.01%. And in fact, there has been now a published series which was published in 2019, which had a larger series where they show that pattern ERG is not affected by low concentration atropine. This is we have not published it. We have just submitted it in this year's the next year's AIOS as a free paper. We could also go and evaluate. We went ahead and evaluate the effect of atropine, if at all, on higher order abrasions, and we found that there was minimal to nil higher order abrasion effect both on coma, RMS, even spherical abrasion, or Z3 or Z4. So I think atropine, we just wanted to see whether it can be used in children less than 6 years of age, just to see whether it affects in any way the higher order abrasion, which may preclude these patients to a risk of amblyopia or things like that. So we could find that there was not much of change in the higher order abrasions. These are few guidelines. There can be an allergy to atropine sulfate. It is possible that you do not get response at this particular concentration. There have been other studies, and I will be having a slide of LAMP study also. Despite saying that it has minimal to no effect on accommodation, there are patients who do complain of near vision problems, and if they are willing, we can give them progressive glasses, or we can they can just stop the usage of atropine. There has been a paper on the accommodative effort, which is partially blunted by low concentration atropine, and in post-op patients did end up into having esophoria, and in 2 patients I think they had manifest ESO also, and they had to stop the drops because atropine 0.01% would only subdue minimal amount of accommodative effort, and this basically makes sure that these children go into a hypoaccommodative state, and they behave like a low AC by A ratio, which converts into an esotropia because of the over effort by the patients for seeing the things for near. So this is another study which has used concentrations, and they suggest that higher concentrations. So for them, they felt that the concentration, if it is increased to 0.025% or 0.05%, is definitely better than 0.01%. We at this point of time, we are using atropine 0.01%, and we do not have any data for 0.025% in Indian eyes. But this was from Yam et al., which was published last year. So we believe that atropine 0.01% are a safe and effective option for preventing the progression of myopia. Obviously, we feel that we need to have more comparisons with higher concentrations, and we have to find out patients, and we have to find out indications for switching to higher concentration, if any. So thank you very much. That's all from my side. Thank you, sir.
Thank you, sir. Thank you very much for nice presentation.
I have one question for Jitendra.
Yes, ma'am.
Dr. Jitendra, in the original Atom series also there were...
Amita, please ask the question at the end of the session. All questions at the end of the session, please.
Okay.
Okay.
Don't forget your question, Sumita.
No, I was just going to ask whether what is his recommendation for non-responders.
Dr. Karamjit, please call the next speaker. Please call the next speaker.
So our next speaker is Dr. Rajesh Sinha. He is speaking on management of VKC in children. Dr. Rajesh, sir.
Thank you, Dr. Karamjit, and I would like to thank Dr. Shukla and all the office bearers of SPOSI for giving me the opportunity to speak in this wonderful midterm virtual conference, and it is virtual because of the obvious reason that we all know. So I'll be talking about vernal keratoconjunctivitis management, VKC management in children. VKC, we all know, is a chronic bilateral seasonal allergic inflammatory disease of eye involving tarsal and bulbar conjunctiva. And the term vernal is a misnomer. Vernal means spring, but unfortunately in majority of cases it becomes perennial, and yes, there is an aggravation during spring, there is no doubt about it. It mainly affects the children who are school-going age group. Mostly 4 to 14, I would say, not 4 to 7. And there is a male preponderance. It decreases with increasing age. So as one reaches puberty, something around 13 or 14, the severity reduces. And it has variable geographic distribution. There's high prevalence in Mediterranean country, also in this part of the world, India, in the Middle East. And there are various factors involved in it. One is, of course, immunological factors. So it is a type 1 immune reaction, and the mast cells, the T cells, eosinophils, etc. are involved in it. Then there are environmental factors that can also cause aggravation of VKCs. And of course, there is a genetic and genetic factor, and a family history of such a condition predisposes another individual of the same family to have it. So as I said, typically it is it is more often in a seasonal variation, in the seasonal change, but a large chunk of these patients are perennial, and they aggravate during these seasonal changes. The usual symptoms that we see is itching, which can be mild to intense depending upon the severity, depending upon the chronicity, depending upon so many other factors, depending upon their surrounding factors, environment, and atmospheric factors. They can have photophobia, mucoid discharge, early morning stiffness of lids, watering, redness, foreign body sensation, and all these can have a waxing and waning course that is typical of VKC. And when you examine it, you can have papillary hyperplasia, hypertrophy, the large size papillae can be there, and that results in cobblestoning, as you can see here in this picture. You can have Horner-Tranter spots, you can have pseudogerontoxin, Maxwellian sign, that is membrane formation can be seen. There can be superficial corneal neovascularization in chronic cases of VKCs, and there can be increased pigmentation of conjunctiva as well, the interpalpebral conjunctiva. It can be bulbar type, it can be palpebral VKC, and it can be a mixed type. There are many conditions wherein you get mixed variety. And there are various ways of grading it. This is one way, Bonini grading, then there's a Gokre grading. So all these things are basically based on various the presence and absence of various symptoms and the various manifestations that a patient has. And as far as investigation is concerned, it is basically an allergic eye condition. And immunological tests have been done, but how it is not routinely done because many of these children who are allergic to one allergen can be allergic to the other allergen as well. And it has been seen in various allergic conditions, systemic allergic conditions also, that detection of allergen does not solve the problem completely. So that's why in our routine practice, it is not routinely done. But yes, we have to rule out complications, and for that we need to do certain investigations like corneal topography to rule out keratoconus, because these children are prone to develop keratoconus. Then anterior segment OCT can be done for epithelial mapping to rule out keratoconus. So all these are the list of complications that you can have. A chronic VKC can lead to stem cell deficiency, it can lead to keratoconus, and that is why it is very essential to tell the parents that the child should not rub the eyes. If the child is rubbing the eye, this means the treatment is not optimal. So the treatment has to be, has to be increased, and further potentiation of the treatment should be done. Then it can lead to dry eye because of loss of goblet cells, because of poor conjunctiva. Then there can be ptosis because of constant rubbing. There can be laxity of the elevator muscles, and there can be ptosis. There can be steroid-induced cataract if the child is on steroid for a very long period, or glaucoma. There can be shield ulcer. There can be corneal scarring as well. So as far as management is concerned, one very important thing is counseling to the parents, because the parents are directly in touch with the patient, with the child, and they will exactly know that whether the child is having symptoms or not, whether the child is rubbing the eye or not, and whether the eye is congested, etc. So all these things have to be explained to the parent, that the child should not rub the eye, and if it's rubbing, then the parent should get the child to the doctor. Pharmacologic therapy is, of course, a very important thing that we all have to think about, and then there are certain surgical modalities which can be done to supplement the treatment of these patients. Now, as far as the pharmacologic therapy is concerned, the anti-allergic drugs that are available are used in these conditions. One is, of course, mast cell stabilizer. Then you have dual acting agent, which we use these days very often. Earlier we used to use, I remember when I was a resident, we used to prescribe sodium chromoglycate and all these. But these days we use dual acting agents, which are like bipotastin or olopatadine or clodophen, etc. And these drugs can be used to suppress the symptoms of the patient. Cyclosporin and tacrolimus, these are the two immunomodulators which have been used very often in allergic eye conditions, the VKCs, and they can be used on a long-term basis, because you can initially start with steroid and then continue with cyclosporin or a tacrolimus for a longer period, because long-term use may not have much of complications in comparison to steroid. As I said, topical steroids remain the mainstay when the patient is very much symptomatic. So low potency steroids are mostly used. Fluoromethalone or loteprednol can be used for taking care of the symptoms. Sometimes the higher potency steroids are needed when the child is not responding and the child is having a lot of symptoms. In such a scenario, high potency steroid can be used like prednisolone or dexamethasone. Difluprednate has been mentioned here, but I would prefer not to use it because there is higher incidence of secondary glaucoma with difluprednate. And even with penicillin, I would like to be a bit careful. But yes, in order to suppress a very severe allergy, one may have to use it for a short period. As far as indication is concerned, as I mentioned, that the topical steroids can be given in most of these cases because they have papillae and sometimes they have ropey discharge, sometimes they have a pseudomembrane formation, etc. Now, supratarsal injection of steroid can be used in certain conditions. When I had shown a picture of that cobblestoning of the tarsal conjunctiva, in such a condition, what happens that you keep using these topical medications but doesn't work much. So you have to be a little bit more aggressive, and you can use supratarsal injection of triamcinolone. 0.5 ml can be injected, and this is how it is injected, about 1-2 millimeters above the edge of the tarsus. You can give multiple injections, and one should always remember that when you are giving the supratarsal steroid, you should always take clinical pictures to see whether the papillae is reducing in size or not. Because many times what happens that one gives one injection and feels that the papillae will dissolve completely. With whatever experience I have, not less than 3 injections are needed in order to resolve these giant papillae which are there. Then some people have used shave excision of giant papillae. I don't have a personal experience of that, but there are a couple of studies which have shown excision of giant papillae and use of amniotic membrane, etc. for that. Then you can have shield ulcer, because if you don't treat these cobblestoning, these giant papillae, they can cause shield ulcer. And if you have a shield ulcer which is not having too much, which is not an advanced one, or like this, having a plaque, you can just treat the patient just like a VKC and it will resolve. But sometimes what happens that you get a plaque like this. In that case, you have to remove this plaque and put an amniotic membrane in order to correct for this GPC, this shield ulcer because of GPC. So and this amniotic membrane, if the depression or the gutter is deep, in that case you may have to put a multi-layered amniotic membrane in that to fill that gutter, and then put an overlay of amniotic membrane. But if it is not of great depth, then you can manage even with this amniotic membrane, just an overlay of amniotic membrane, and that takes care of the shield ulcer. So this is what you have a large management algorithm, and I will not go into every point of this. Rather, I would just like to summarize by saying that VKCs are chronic conditions, a condition that needs a long-term treatment, and a long-term treatment by a combination therapy. You use steroid to get a fast resolution, and then of course you continue with something like, say, cyclosporin eye drops or a tacrolimus and dual acting agents. So a long-term treatment is required. Along with this, I also advocate use of lubricants, because lubricants not only provide smoothing effect, provide symptomatic relief, but also wash off the allergens. Now, when you're using steroid, you have to taper it off gently and follow up the patient very, very meticulously. And what is most important is that you should look for any complication that has happened, or there is risk of any complication. So these patients, they have to be, monitored routinely for, complications like stem cell deficiency or keratoconus, etc. And topography and investigations. These need to be done routinely. So that is very essential. And for all these, what is most important is a very good parent counseling. Counseling of the parent to have adequate, optimal outcome of management is the most important thing. Thank you very much for your patient listening.
Thank you very much, sir. Thanks for nice presentation. So our next speaker is Dr. Vishali Gupta. She is speaking on pediatric uveitis and overview. Dr. Vishali, ma'am.
Thank you very much, Dr. Shukla, Dr. Karamjit, and Punjab Ophthalmological and Pediatric Society to give me the opportunity to speak. Am I audible?
Yes, yes, ma'am.
Perfect. So my topic is pediatric uveitis. How do you manage? I'm not going to give a book talk, which for uveitis I stopped giving because kind of makes it very boring. So I'm just going to give very 5 practical tips that I hope are helpful to the attendees. The first is the classic symptoms of pain, redness, and congestion. Now, these photos show uveitis in an adult patient. And this is what we have all grown up with. If you see uveitis, you expect pain, redness, decreased vision, congestion. Just remember that children, when they have uveitis, it just may come in a white eye. You may not have any congestion. Children will be asymptomatic, no complaints. All you see is a band-shaped keratopathy, complicated cataracts, some sign leaky. So don't be in a hurry to refer it to the cataract surgeon or to the cornea surgeon, because if cataract is done in a hurry, these are the kind of eyes which will end up in phthisis bulbi. The second mistake that we all make, because we all read textbooks and we are very fond of textbooks somehow, you know, the etiologies of uveitis would be very different in children compared to their adult counterparts. For example, if you see acute anterior uveitis, it will depend on the age. If it's a middle-aged man, think of the autoimmune causes like you would think of Angst-Font and other HLA-B27 related. But when it comes in children, think of etiologies which may not be commonly taught, but which are very rampant. For example, you may have juvenile idiopathic arthritis, pediatric sarcoid, Blount syndrome. I don't have time to go into all this, but we are seeing quite a lot of patients who have these kind of disorders. And why we need to pick them up? We simply need to pick them up because these are the kind of the children who would respond to biologics and not to the routine steroids and immunosuppression. The third important corrector is masquerades need to be ruled out. Uveitis, when you see either in children or in elderly patients, always, as a rule, root out underlying malignancy. Now, this is an 8-year female child, and she was being treated as pars planitis from one of the very reputed centers of the country for 2 years on immunosuppression. You look at the slit lamp. These are large cells. These are not WBCs. You look at the vitreous. These are storm of cells which are too large cells. So when you see these big cells, always rule out malignancy, especially if it is a child. Now, this child underwent quite a few tests, but most important of these was CT scan, which showed calcification, showing it could probably retinoblastoma. We wanted to know what these cells were, so we did go in keeping the eye ready for ERBT and enucleation or whatever required, and these were the cells which showed round tumor. And this is what I would like to bring your attention to, that if you see large cells or you see these pearly white deposits in the anterior chamber. Now, these deposits are something very characteristically seen in malignancies, including retinoblastoma. The fourth thing to remember is disease tends to be more severe and would have more complications. So you do not have time to waste. You do not have the luxury of just ordering investigation, waiting for it, because it can just go into phthisis very fast. Now this is what I was showing you. This is what looks like complicated cataract. And if you are not paying attention, you might just say that it's a complicated cataract and there is no active uveitis. So let's just go in. You know, that's the mantra for our cataract surgeon, that any white thing you see in the eye, just go in. But it's very important to look at the eye as a whole. For example, if you do UVM in this eye and the bottom panel, in the left eye, you see there is total hypotony. There are no ciliary processes, and you also have a cyclitic membrane sitting with it. So if you do cataract, it's going to go into phthisis. So it needs a management which includes no ions in JIA at all, doing a good lensectomy, peeling off the ciliary membrane under endoscopy by expert VR surgeon, and if required, filling the eye with silicone oil to prevent hypotony, and under very high dose of biologics and steroids. The fifth thing to remember is the systemic associations are more common in children with uveitis compared to the adult counterparts. Now let's see how. We have an 8-year-old girl which is unilateral, and you can see lots of cells and KPs and circumciliary congestion. The vision is down, its hand motions close to face. Now this is what her fundus looks like. There is a lot of exudation, and the first thing was, is it a coats in a young girl? Which we all know coats doesn't occur, but then we did not have a better diagnosis. The fluorescein shows the right eye presence of leakage at the level of the capillaries, and there was exudative detachment. And the late phase showed significant leakage with vascular permeability, but it did not show classical feature of Coats disease like lighted bulb, aneurysmal dilation, or anything. So what are we dealing with? Unfortunately, in ophthalmology, we get used to looking at the eye and not looking at the patient as a whole. So when you look at the patient, there was something which is not right. And that was, we should have picked it up the moment child walked to us, but we are so fond of, just putting the child on slit clamp, looking into the retina. The child had zygomatic bone prominence with atrophy of the periocular pad of the fat and deep cell size. So she had a right-sided hemifacial atrophy, as you can see, with the prominence of zygotic. And we, of course, took out the older pictures, and all these changes were progressive. So this was actually what we were seeing in the retina, and the uveitis was a part of Peri-Romberg syndrome. And the rest of the investigations and how would you manage, you will not only control uveitis, but you will also take care of her systemic manifestations. We did give Lucentis for the exudation, but she did receive treatment in form of biologics by our rheumatologist. And you can see that she was responding not only in the eye, but her progression of the hemifacial atrophy could be stopped to some extent. I don't say it was reversible, but further progression could be slowed down. My last case, again a young child, walks into the clinic, asymptomatic, nothing, and you see these vessels here are dilated and tortuous, and if you see carefully, she has hemorrhages into the retina with the white center on them. So the first thing we do is the OCT through these blood vessels, which shows them to be uniformly hyperreflective. So in future, if you see these vessels uniformly hyperreflective on OCT, always rule out leukemias and the dysproliferative disorder because these are indicative of hyperviscosity. So of course we did all the tests and she came out to be suggestive of chronic myeloid leukemia. I won't go into the details of it, but this is normal, which shows a sign of 8, and if you see it missing, it could simply be any of the myeloproliferative diseases. In this patient, it turned out to be leukemia. So I'm not going to go into very hardcore details, but I just wanted in these 10 minutes to bring home a point that uveitis in children is very, very different from the uveitis in adults. It needs a very special care, and you've got to be very vigilant both in making the diagnosis, but at the same time not wasting time when you are making the diagnosis, because you would need to start therapy very fast. And in case you are in doubt, just refer the patient to the center where it can be managed, because just giving steroids and postponing these patients will end up in a long-term complications, including thysis bulbi. Thank you once again for giving me the opportunity to speak, and I'll be happy to take any questions.
Thank you very much, ma'am. Thanks for a nice and elaborative presentation. Our next speaker is Dr. Santosh Honavar. Dr. Santosh is here. Dr. Santosh, I think he has not joined the meeting. So we will take up a few questions from the audience.
Yeah, you take the questions now.
Questions from the
I
audience.
have a question for Dr. Rajesh Sinha, sir. When you are injecting steroid supratarsal, so what specifically you are doing just to avoid the ptosis to occur, and how frequently you give second injection if the condition is regressive?
Well, it has to be, the standard procedure has to be followed, and you just invert the lid and go 1 millimeter above the tarsus and go just subconjunctivally so that you don't, penetrate the muscles and all that. Then inject, we usually inject tricot 0.5 ml, that is 40 milligram per ml, so 20 milligram we inject. And after 3 weeks time, you see whether how is the response, and then with the response, you just, if there is slight response or whatever, if there is even there is slightest response, then you have to repeat it, because the minimum number of injections that we have seen in our clinical practice is 3 in order to resolve these cobblestoning completely.
Yeah, but it's most of the time it's very difficult just to not to go in muscle, because somehow you hit muscle, at least molars. So I just wanted some practical tips if you are following not to.
Yeah, it's just you just have to go underneath the conjunctiva, and it will be actually between the muscles and the conjunctiva. So you just have to go. You don't have to go deep underneath. You just have to go just underneath and inject. So for that, you may require multiple sites injections, but don't try to go once and then proceed further with the needle and go in the middle and go to the other end. Otherwise, in that case, you will hit the muscles. So at 3 points, you can inject and just go superficially and just underneath the conjunctiva. That is how it should be.
Right. And you're using some specific needle, like 30 gauge or only 26?
26 gauge needle.
26. Okay. Thank you.
Sir, question is to Dr. Rajesh.
Yeah.
Sir, what is the maximum time for which you have given topical tacrolimus at a stretch?
Maximum time that I've given at a stretch, I think it's difficult to remember, but yes, normally when you are giving for these VKCs, you do require tacrolimus for a long period, something like maybe 3 to 4 months time. And but mostly tacrolimus I prefer giving at bedtime, not during the morning time if possible. If it's if the severity is too high, then you can give it morning and evening. But better is give it in the bedtime, because in the morning if you give, then the child has to go to school and there's so many issues. Since the ointment will spread over the cornea, there will be blurring, etc. So you do have to give it for 2, 3, or 4 months time. Then only you get a response, and it is variable depending upon the response. You reduce the drug.
Yes, we can give for 3 to 4 months without any toxicity.
Yeah. Yeah.
But another question is the role of tacrolimus ointment in VKC, that already you have answered, I think. So another question is Yesh also. What is the anterior segment OCT finding of early keratoconus in allergic conjunctivitis?
See, ASOCT is done to look for the earliest changes in corneal epithelium. So what you do is that you do Fourier domain OCT to look and to do you do the epithelial thickness mapping. And keratoconus is a known entity in cases of VKC. If the child does a lot of eye rubbing, then there is risk of keratoconus. So in ASOCT, you can get, when you do epithelial thickness mapping, you can get some amount of thinning of epithelium, particularly in the inferior part, inferonasal, inferotemporal. In that case, you may suspect that the child.
Dr. Rajesh, are you there on the line?
Yeah.
Dr. Rajesh, I want to ask you a question for the audience sake. See, we have a lot of problem in this country for VKC. We have number of drugs which we have in our armamentarium. Tell me, the exact question is that how long, because we start with steroids, we all know about it. How long should you go? Because I have seen, and everybody has seen, lot of cases going into PSC cataracts. Long time they have been using steroid and then gradually going into a posterior PSC cataract. I just want to say for the audience sake, how long should you give steroid and then add tacrolimus or add other sodium chromoglycate and all the ancillary drugs, adjunct drugs? What is your protocol?
Normally we start with steroid, and depending upon the severity, like steroid along with that dual acting agent, and if needed, cyclosporin or tacrolimus. In a combination therapy is started, and then gradually you taper off. So there is a general saying which we have been listening, that 760 drops of dexamethasone can cause cataract if given a stretch. So that is a general saying, but it cannot be a hard and fast rule. So
normally we start, in my practice, we start with fluoromethalone or
fluoromethalone, yes. So I mean, that rule has not been there for fluoromethalone actually, because this was made long back, and this was with dexamethasone actually. So normally we give fluoromethalone for.
Yes, Rajesh.
Yeah. So normally we give fluoromethalone. Along with that, we give cyclosporin and dual acting agent. And as there is response, if there is a good response, then we gradually taper off the fluoromethalone. If there is no response, in that case, we may consider giving a supratarsal triamcinolone in such a case.
No response means what time period? Because we don't give steroid content for more than 6 weeks. Standard.
Yeah. So, see, the response has to come in terms of symptoms, in terms of reduction in size of papillae. So, if the child is not responding, and particularly if the child has come to you in the initial presentation with cobblestoning, with large papillae, in that case, one may prefer giving supratarsal steroid in that, and then continue with fluoromethalone. Now, fluoromethalone can be given for 3 to 4 weeks or 5 weeks time. Only thing is that you start with 3 to 4 times a day, and then gradually you taper it off. And then the cyclosporin and tacrolimus and the olopatadine or bipotastine takes over along with lubricant agent. So,
I think I will just say I'll do a little differently, and that is I do feel that in vernal catarrh, especially the severe ones, you need to break that vicious cycle of inflammation, which is immunologically mediated. So in very severe cases of vernal catarrh, you may have to even give systemic steroids to break that vicious cycle. And if I have to give steroids, I don't like to give fluoromethalon or low potency steroids, because it has to be hit hard and it has to be, you have to just stop it at that. So I rather would go in for a stronger steroid, which could be a Pred-Fort or a Pred-Acetate, break the cycle there and then shift on to also give simultaneously tacrolimus or cyclosporin. And within 6 weeks, my titration would be that I have to stop steroids, because that is the point I know my second drug, that is tacrolimus or cyclosporin, would start acting. So, and if it is steroids, I think it has to be a full-hearted, attempt to just break that cycle there. Because once you break that vicious cycle, then it becomes very easy. Otherwise, it just keeps going on and on.
Systemic anti-allergics like fexofenadine also helps in children particularly, because that also helps in breaking the cycle, as
And ma'am, what dose of
I don't use systemic steroid. I use systemic fexofenadine instead of systemic steroid.
My question is, sir, like, what is the experience with the recent onset anti-allergic drugs like alcaftadine and bipostatin? Do you find them equally effective as compared to olopatadine?
See, there are studies which have shown that they are quite effective. As such, unless we do a randomized study, it is very difficult to say whether they are equally effective or they are less. But there are a few studies which have shown that they are equally effective. So I guess
Dr. Rajesh, in my practice, what I've seen a long age, almost 38 years of practice, the people have to do combination and permutation of lot of things. We never know. Even I have seen patients with a moderate amount of VKC stabilizing on just, decongestant drops and mild chromoglycate, So the response of individual child or individual patient is very different. You have to, do a permutation and combination of things, and what is best suited for the patient, you should do that. Because we have a lot of drugs now, as olopatadine, and these are also coming, bipostatin. Even a single drug response has been miraculous in some patients. So you have to, make your own judgment as far as that, I think.
That's very true. That's very true.
So actually, I have a question for Dr. Namrata Sharma. Madam, how long do you, for systemic steroid, how much do you give for VKC?
So we would give the same dose as we would give for any steroid. Of course, it is going to depend because it's going to be a child, so it is going to be a little less. But this is only given in severe cases of VKC, where you want to break that cycle of inflammation. And cobblestoning, of course, cobblestoning has helped very well with triamcinolone steroid, as Rajesh said. But there are other methods. Sometimes you have to do papillectomy. Sometimes you have to do AMG. Sometimes you have to do even mucous membrane grafts, which Rajesh also highlighted. Because the mechanical irritation will go on and it will not stop. It will again, the cycle will keep perpetuating. So to stop that again, you need to put barriers like this. So that, sometimes what happens is you've given steroid and the papillae, they've become less congested, but they don't go away. They're still sitting there. So if they're still sitting there, then you have to even do shave excision, or best for that would be you shave it AMG over it.
You can also give a subconjunctival triamcinolone injection, what Dr. Vash is saying. That has also been good in large papillae. I think we are running out of time. One last thing I want to tell, because this is very important. VKC is very, very prominent. Prevalent in our country. Cold sponging or ice packs are also a very good adjunct treatment. What I have seen in so many patients, you do a ice pack morning and evening for 10 minutes. You reduce the drugs by half. This is, I think everybody should do it.
Very true.
Isn't Rajesh? I think shall we stop? Audio आ रहा है आपका? We are able to hear your audio. आप 5 मिनट audio से बोल दो फिर और क्या?
Okay. What I wanted to tell you was that my system works for treatment of amblyopia. The main advantages of this system are it works in 95 to 96% of the cases. Number one, unlike patching, which works in 75% of the cases. And number two, it works in a much shorter time, like in a month's time or less than a month's time, depending on the type of amblyopia. And it lasts
for a longer time without needing any special re-intervention, in the sense that once the patient is treated with this machine for at least 1 month, depending on the age and type of amblyopia, and they need to come back every 2 months for 6 months, and every 6 months for 1 year, and then every year they need to come back to get one treatment for 1 hour. Now, how the system works is because I am looking at the whole of amblyopia in a different way. What we are doing is we are trying to, it says you are screen sharing. I don't know whether you are receiving or not. Can you hear me? Hello?
Yeah, carry on.
Okay. What it depends on is, we know that the impulses go from the retina to the occipital cortex, and then they go beyond the occipital cortex to the various places within the brain. So we all have been taught that the occipital cortex is at the lower level in the hierarchical system of vision, and the other areas at the higher level. No. The answer is they are all at the same level. Whether it's occipital cortex, parietal cortex, frontal cortex, they are all at the same level in terms of hierarchy in the brain. So when the impulses from the occipital cortex are not forwarded onto the other cortices, like parietal cortex, temporal cortex, etc., the effects on the rest of the body will be magnified by these. However, we also must remember that the temporal cortex and the parietal cortex have a flow-back connection. That is, this is what is called as top-down impulse to the occipital cortex. Now, in amblyopia, what is happening is the occipital cortex receives the impulse, but it does not pass it forwards onto the other cortices for the brain to analyze what is this impulse that the occipital cortex is receiving. So once they are not forwarded to the other cortex, particularly there is an area called attention area in the posterior parietal cortex complex. This attention area receives
Dr. Kamil, sorry, Mohammed Kamil.
Can you hear me?
Yeah.
Yeah, okay. Now, what happens is the occipital cortex fails to send impulses to further forwards because there is a block at the occipital cortex. However, what I am doing is I am obviating this block and coming from higher end like temporal cortex and parietal cortex back onto the occipital cortex by what is called as the top-down impulses. And when I bring the top-down,
I think I have a message from the enrolled people that the time slot is over. It was up to 1:30, but we still, carried on up to 2 o'clock, so we have to stop here. Dr. Khokar is there? Is Dr. Khokar online?
He left for another webinar, sir. I received his message, right?
Acha, okay. So, is Dr. Pradeep Sharma there?
Yeah, I'm there.
Dr. Pradeep Sharma.
Yes. Hello.
Yeah, come on the screen.
Yeah, I am on the screen.
Okay, so can I have your comments? You are the immediate past president. Can we have your comments? The closing comments, please, for the session.
I think I'm very heartened, because this was something which we were all feeling scared about, not having the midterm this time, in spite of the interest that Amritsar has taken for the first time to have a midterm, and we would have been missing it. But I think because of this webinar, that lacuna has been fulfilled very nicely. I think congratulations to the Punjab Ophthalmic Society, and particularly Dr. Shakeen Singh and Dr. Karanjit Singh for taking that enthusiasm. It was difficult getting so many people together, and also I would like to congratulate my dear friend Dr. Yogesh Shukla for making such a good program in a short time, for accommodating all the people who could be available, and all the presentations were wonderful. each one has done wonderful, and even the panelists, I am really thankful that they have taken so active participation in this. So it all is something which we can say strabismologically yours. We all are for that, and let's clap for the SPOSI once. It should be a large thunder clap.
Thank you very much, Pradeep ji. It has been a cooperation and collaboration from all the panelist speakers, and I think Dr. Karanjit would tell me how many viewers have logged in. He had promised me more than 2,000. Let us see, Karanjit, do you have any idea?
Sir, right now it is not displayed on my phone. After the end, sir, I will message. I will post that in the group.
Okay, so this would go into our the SPOSI. I have to put it on the SPOSI website. That how was the work. So this is first, as Dr. Murata also said.
At 11:30 we have 858 people, sir.
Wonderful.
Okay, very good. At least this is more than what we have in the annual conference. Much more than what we have in the annual conference.
And this is going to be cumulative. This will keep on adding.
Yeah, this will keep on adding. Very good. अब आप सब लोगों की जो जरा नवाजी है, आप लोगों की मेहनत है, आप लोगों का जो है इसमें जो योगदान है वो सराहनीय है. मैं आप सबसे हाथ जोड़ के आपको धन्यवाद देता हूँ सब लोगों को. And with that, we close this.
सबसे बड़ा योगदान आपका है सर.
From Punjab Ophthalmological Society.
From Punjab Ophthalmological Society, yes.
Our seniors, Dr. Pradeep Sharma ji, Dr. Yogesh ji, Dr. Kamlesh ji, and all other seniors and members of SPOSI, Strabismological and Pediatric Ophthalmological Society of India, that you gave us this opportunity to hold this webinar. Actually, we want to make this event a big in our institution because we are celebrating the second year of our medical college, Government Medical College, Amritsar.
Okay, yes, you told us that, yes. नहीं तो आपका बहुत अच्छा रहा है. This has been, you see, as Namrata had said, that is the first webinar of a registered society. So it has gone very well, flawless gaya hai. Everybody.
It's the first virtual conference actually.
Yeah, actually, it's a virtual conference. Yes.
Very good, sir.
Yeah, very wonderful.
It's a virtual midterm conference.
Virtual conference. So I
thank you, sir.
I would just close by personally thanking Dr. Karanjit and the Punjab Ophthalmic Society for taking this initiative, and it has been really wonderful. Now it has given us, stimulus that we can do it every 3 months on different subjects of ophthalmology, pediatric ophthalmology.
Yes,
and I would like to have people come forward. Jitendra, मैं देख रहा हूँ, तुम्हारा नंबर भी आएगा. Jitendra, are you listening?
Yes, sir. Yes, sir.
Jitendra is there, Shreya is there, and also let's go forward. Let's join hand and go forward in this.
Sir,
I would like to thank
it's wonderful idea.
From
isn't it? Yeah, that's a good idea.
सर रोहतक है, रोहतक में डॉक्टर खुराना है, हम भी हैं, we all
आज रोहतक में तो आपसे एडवर कराएंगे, इससे थोड़ी छूट हो गया 3 महीने की वाली से.
I would like
I think there is a message coming from the Entor that we have to close. So the time slot is over. So once again, everybody, Dr. Rajesh, Dr. Namrata, they are the new entrants to this SPOSI.
ये अभी सोचना पड़ेगा. एजी
नहीं वो तो 25 यार तो
वो तो मिलेंगे.
अरे अच्छा बोलो यार, शुभ बोलो. क्या काय को ऐसी बातें कर.
मेरे हाथ में थोड़ी है.
मिलना नहीं करेंगे हमेशा,
आप लोगों के हाथ में है. अरे आप लोग आओगे तो बिल्कुल होगी. डोंट वरी यार, ऐसा मत बदुआ लगाओ यार. तुम जीते
आप 23 स्टेट में सुकुल जी.
हाँ क्या यार, ऐसी की बात है.
But still we can have these webinars more often.
Yeah.
Yes.
Thank you very much.
And thank you to Entoad also, sir. They've done a wonderful job.
Yeah.